Good morning. Can everybody hear me? Good morning. Wassalamu alaikum wa rahmatullahi wa barakatuh. Welcome everyone to this important event from INTERYem. We welcome you as panel and also as attendee and lecturers, guest speakers. This is one of our conferences that is dedicated to Yemen, bringing people from various parts of the world and Yemen, bringing their experiences, bringing their insights, and seeing what can we do about the evolving situations and dire need for healthcare in Yemen. This particular event is centered around infection. And as we know, infection is one of the leading causes of death for people who require medical treatment. This is even more so in areas where there is healthcare challenges, such as in the Yemen. And just to remind everyone, INTERYem is a charity organization which aims to empower the people of Yemen through research, education, and training. There are many other organizations which provide different facets of healthcare provisions and healthcare development. We wanted to be on the forefront of being one of those who actually contribute to training, education, research for health in Yemen. Please welcome all the guest speakers today who have spared their time and busy schedules to come and join us here today and provide their insight and expertise. Into the show and just check that everybody is here today. If you could just unmute yourself.
Hello, good morning. Assalamu alaikum.
Wa alaikum salam. I'm really sorry. I think just my connection, I'm still in the hospital. That's why I Dr. Khan, thank you very much for coming. Dr. Khan is a consultant microbiologist. She has a wealth of experience in this field, and she will be our first guest speaker today. And we welcome you. Please join in. Thank you.
Good morning. Assalamu alaikum. Thank you, Walid, for your kind words and the opportunity to chair this morning session on overcoming sepsis. As most of you in the audience would already be aware that sepsis is a life-threatening condition caused by the body in response to an overwhelming infection. The UK Sepsis Trust estimates that sepsis causes more deaths than combined bowel, prostate, and breast cancer. And the mortality rate is extremely high if sepsis is not recognized and treated on time. So hopefully by the end of the talk, we all would have gained more training and education on tackling sepsis. Our first speaker for the day is Dr. Najib Rahman. Could we check if Dr. Najib has joined us before I start introducing him?
I think this Dr. Najib is perhaps joining late. He's one of the infections, sorry, for the emergency department consultants in our hospital, and he has a wealth of experience in international global aid. So
has Dr.
who would
Najib
be
joined us? I'm not able to see him. Sorry.
what we'll do, Dr. Khan, I'm gonna get in touch with Dr. Najib. If you carry on, I will get in touch with him.
All right. Okay, no
To
problem.
make sure that he's got no difficulties. Yeah, thank you.
Okay. So, whilst we wait for Dr. Najib, I can quickly talk about Dr. Najib. So Dr. Najib Rahman studied, trained, and works in the UK. He is currently a consultant at the Leeds Hospital in emergency medicine, and is also a trustee of Doctors Worldwide, which is a UK-based international medical charity. In addition to being a fellow of the Royal College of Surgeons, Edinburgh's Faculty of Remote, Rural and Humanitarian Healthcare. Dr. Najib has a passion for global emergency medicine and humanitarian assistance, and holds a diploma in humanitarian assistance, as well a master's in public health, as well a master's in global healthcare leadership. So I'm really delighted to introduce Dr. Najib to the room, and over to you, Najib. Thank you. Looking forward for the first talk.
Thank you. Assalamu alaikum, everybody. Assalamu alaikum, Wahib. Nice to see you all again, and thank you for the privilege and the honor to be able to speak to this distinguished symposium and for the kind introduction. Now, I know they say you shouldn't start off with an apology, but I'm going to have to apologize because I'm actually traveling at the moment, and so I'm not using my normal device. So we're going to try and do this presentation as a combined effort. So can I confirm if Mubashir is there? So are these just the sets of slides, or is this the video? Could I just try and confirm? If it's the video, then we can play it. If it's just the slides, then I'm going to have to keep prompting someone just to change the slides, if that's okay. Just the slides. Okay. Okay, so as long as someone's happy to kind of move the slides forward, that would be great. So next slide, please. So I think one of the key things here, sepsis, when we talk about it, I think you'll probably find there are practical definitions, and then there's practical implications. You know, what does this mean for us locally? And I think herein lies one of the biggest challenges when we look at global context, what we already understand about it, and then how do we then bring that into our practice? So as part of that, we're going to look at some definitions and some global context, because I think global context is really critical here. We're going to discuss what an approach is from an emergency perspective, and in particular, zoom down a little bit about triage and first steps. And then we're going to end in just some, reality reflections, really, before we go into Q&A, inshallah. So next slide, please. So this is the important one here. The issues I've highlighted in red are really the takeaway points from this perspective, right? Sepsis here is a life-threatening condition. So this isn't something we can just ignore. There's excess mortality, excess morbidity linked to the condition of sepsis. And it usually results from severe infection. So it's secondary to something. But the complication here, the thing that we have to be tuned to is, why is it life-threatening? It's because of the organ dysfunction and failure that our own body's immune system causes. So our body reacts to an infection. That infection causes organ dysfunction and failure, which then leads to the life-threatening nature of things. So those are kind of a spectrum and a pathophysiology that we need to understand, because that also changes some of our approach in the acute setting. Next slide, please. So global. This is interesting. Now, this is actually from a WHO paper that was published in 2020, but using 2017 data. And I think this is important to kind of highlight in a few things. Globally, almost 50 million cases of sepsis worldwide. So huge burden, absolutely huge burden. The largest contributor to sepsis was diarrheal diseases and lower respiratory tract infections. And again, I want you to reflect back on what we discussed as the definition. So you might get a diarrheal disease, which will not progress to sepsis. But if you start to get that overwhelming response from the body, that immune response, that's when sepsis can develop. It's similar to respiratory infection. So sepsis is not discriminatory based on the kind of infection necessarily. So we could diagnose that, but the key issue here is how do we then manage things moving forward? The biggest burden here is 20 million, so 41% in children less than 5. So again, a huge burden in the very young population. 11 million deaths, so 1 in 5 all-cause deaths worldwide due to sepsis. And almost half of those deaths were due to injuries and non-chemical diseases. And then clearly we know that low-middle income countries or less economically developed countries, etc., these are bearing the disproportionate brunt of sepsis-related mortality. So I think it's important to frame this as a prioritization of approach. Next slide, please. But herein lies one of the challenges. So those studies that we quoted that was used to calculate that evidence, the majority of those papers have come from high-income countries. So this is another big challenge. So how do we even know the genuine burden of disease when we're not even measuring it in most parts of the world? So although there might have been, appropriate epidemiological approaches to extrapolate the data from high-income countries, etc., but it's never the same as actually knowing what's happening locally. And so again, in 2016, 2017, when the data was published, there was still very little available locally. Now that has changed over the last 10 years or so, where there's a little bit more information coming out from papers. But I think just again important to acknowledge that. Next slide, please. So that global perspective, again, is important because this did lead to the World Health Organization during the World Health Assembly issuing a resolution to really focus on the prevention, diagnosis, and clinical management of sepsis. And this is across kind of 6 themes here: infection prevention and control, so IPC, a focus on antimicrobial resistance and stewardship, so appropriate management of antibiotics, how you start them, how you look at the sensitivities and targeted therapy, how you stop them. The role of health emergencies. Now, this is a public health term of health emergencies, so not emergency medicine in the way that I would think about it within a clinical setting, but health emergencies from a population perspective, where you get pandemics, epidemics, outbreaks, and what is the role of sepsis management in that kind of context. Also looking at health promotion, what do communities understand by the condition, different healthcare providers, how do you raise awareness of it, and how do you raise advocacy around key clinical conditions? And it goes without saying that linked to strengthening our response to prevent, diagnosis, and management, we need training, research, innovation. We need to understand standards and guidelines. We need to be able to monitor and evaluate how effective our policies are. So what you're seeing out here is an integrated approach from a policy perspective of how to address sepsis. Next slide, please. So just to kind of break this down a little bit further, when we look at these service themes around integration and approaches, and I want you to reflect in your own setup, how connected are you along these themes? And again, we need to sometimes move away from thinking purely vertically around a single condition. So not just sepsis, not just myocardial infarction, not just pediatric health or maternal health, but to think about how do we strengthen across the board where everyone's health can be optimized by having good systems in place, whether that be universal healthcare coverage, whether that mean assessing the capacity and capability of your institutions. The WHO is producing this tool called the Core Clinical Readiness Tool. It is not yet fully launched, but keep an eye out on the WHO website. You can Google this maybe in the next few months and see if that tool comes up, because that will almost help you to audit your own services. Again, thinking about that early recognition at community pre-hospital levels with triage. Now, for us, what we're going to spend a bit of time on is this resuscitation and early antibiotics. Very straightforward in some ways, but you do need dedicated areas. You need to understand some basic emergency care, which I know some of the speakers are going to talk about in greater detail. The issues of checklists and standardizations, etc. Next slide, please. So when we think about Yemen, how to put some focus on here. Now, herein lies the dilemma. Now, this is data from the health cluster from 2020. At that time, only 51% of healthcare facilities were actually fully functional and accessible to the public, meaning, relatively free public healthcare rather than private. So private healthcare might be slightly different. And I know there'll be a range of service provision. But for the general public, 51% is what was working. And of those facilities that were surveyed, only 37% had a full package of services, where that means integrated care with maternal health, pediatric health, etc. There were no doctors in 49 of the 276 districts that were surveyed. So 18% of the districts that were surveyed had no doctors, and another 42% had less than 2. So there's a huge human resource for health burden here that we're talking about in Yemen, let alone the healthcare facilities and infrastructure. From an infectious disease perspective, very different profile to the UK. And so, again, there's this question about what do we understand about the management of these conditions from a sepsis perspective? What is common, what is different? If you get sepsis due to cholera or due to pneumonia or due to malaria, is the approach different? Next slide, please. So what is an emergency approach? And I've tried to kind of spell this out as 2 linear processes. So there are these themes in the red where you have to recognize a problem, resuscitate, review, and then refer. You'll see there's nothing there about diagnosis per se. And I think this is one of the key concepts in emergency care, is that you don't often need to have a diagnosis for yourself to actually respond to something. And in the blue row, I've kind of put a little bit more detail here as to what might be done in those processes. So to recognize means you have to triage. So that means screening through a range of cases to try and identify the high risk ones, get them transferred to an appropriate area, hence the resuscitation room as a dedicated area. Treat and investigate. So you're treating, simultaneously investigating, and there's a review process. And again, you can see there's this constant review cycle with resuscitation, because if things haven't worked the way you want, you have to continue resuscitation. You don't move forward. Similarly, that means as part of review, you're monitoring, you're choosing what you want to monitor with certain goals and outcomes, even for that care. So a change in blood pressure, or a change in a blood result, or a change in response. And then you plan accordingly. And again, there's this loop between treatment and investigations. If you're monitoring and planning isn't quite working. And then you need to refer. And refer to who? So this could be referred to another part in your department, depending on your layout. It could be to get specialist input. And then from a safety perspective, an appropriate handover of care. And again, that specialty input and handover might require further treatment investigation. So this is this approach I just want to discuss. And we kind of know this already, and we probably do it already, but I think it's helpful just to frame in our mind what it is we're trying to achieve when it comes to trying to manage a particularly ill patient. Next slide, please. So early recognition. One of the big challenges when we talk about sepsis is it is non-specific sometimes. So how do we distinguish between serious illness of any other cause versus infection as the main driver for someone presenting really unwell? I think there's also recognition that septic shock is a subset of sepsis. So, you've got sepsis as this overarching acute illness, and septic shock is this high risk, high mortality burden subset condition. We need to pay attention to high risk groups, so vulnerable groups. So these might be very young babies, children, the elderly, those with suppressed immune systems, those with other comorbid infections or comorbid illness as well. So maybe diabetics, etc. So think about malnourished patients as well. So think about those high risk groups. From that sepsis perspective, one of the key things is, do you actually have a suspicion of a likely source? So maybe if there's something like an indwelling catheter or a cannula, or has there been a history of something that suggests an infection, respiratory or diarrheal or otherwise. So there's that conditionality between, okay, how do we distinguish between a serious illness and an infection versus a likely source? And then again, as part of that early recognition is almost simultaneous early assessment to initiate early treatment. Next slide, please. So as part of that triage process, again, I wanted to focus on some signs and symptoms. And again, some of these are non-specific, as you can see. Okay, fever, low temperature, shivering, that might suggest your infection. Not 100%, but actually that is probably pretty useful. But these other ones, they just help to demonstrate acuity, right? How unwell is someone? If they're confused, do they have difficulty breathing? What is their skin like? Is it clammy? Is it sweaty? Are they in severe pain? That might suggest a surgical target, for example. What about their basic physiology, their heart rate, the pulse, the blood pressure? Urine output is a very good marker as well. And again, we're trying to, again, understand this idea of organ dysfunction. So a lot of these elements here are generic to demonstrating end organ dysfunction and damage. If you're not perfusing your brain, not perfusing your limbs, not perfusing your skin, etc. Now, in children, fast breathing can be a concerning sign, as can be convulsions. And convulsions don't have to mean a meningococcal encephalitis kind of picture. It could be just purely secondary to overwhelming sepsis. The skin might change in its again, lack of perfusion, so mottled skin or pale skin. And again, we have to remember, a lot of these descriptors are done in high-income countries, majority in the West. What will skin look like in non-Caucasian patients as well is something to consider. Lethargy, difficulty to rouse or wake up. And in the young kids, so less than 5, difficulty feeding, vomiting, reduced urination. So asking about, are the nappies wet or not? Are they feeding okay or not? These are all triage elements. So again, you're not looking for a diagnosis. You're trying to understand the risk of severe illness in a given patient. Next slide, please. Now, this won't project very well because it's quite detailed, but I've put the reference on the side. And essentially, if you then Google the WHO Interagency Integrated Triage Tool, you'll be able to find these resources. And again, compared to the slide before, where we looked at some of the headline figures around sepsis and infection, these are the generic triage tools that WHO can recommend. You might have your own local resource already, which is great, depending which system you're following. But if you don't have a system in place, instituting triage is going to be critical. And there's a tool for greater than 12s, and there's a tool for the less than 12s. And again, the way this works, you look at the red criteria. If there's red criteria that the patient meets, again, not a diagnosis as such, but some severe signs or symptoms, you move them straight to a dedicated area for resuscitation. You might say, what's the point of having a dedicated area? This is partly to do with the way we behave as practitioners, our cognition, and also allocating our resources. This might be the only bed or bay that you have oxygen available, that you've got a working monitor available, and maybe you can supply at least another healthcare worker, maybe a nurse or someone similar. So you're trying to put you're optimizing your resources in a designated area to prioritize the illness of that patient. Now, let's say they don't meet any red criteria. They can go to a yellow zone. They still have to be seen pretty urgently, but at least we know that they don't need immediate interventions, right? But yellow is still urgent. And the last bit, you then look at some key physiology, so some vital signs, etc. And based on this, again, if you meet these high-risk vital signs, you get upgraded again for urgent clinician review. Whereas if the vital signs are all within reasonably acceptable margins, you can then wait for a little bit longer. So just a concept again about triage here, about that the initial triage is often based on symptoms and signs as opposed to pure numbers, but there's also vital signs that go into that calculation and decision making. Next slide, please. We missed one before, but it's very similar to the previous one, but essentially it was focusing on less than 12. So we'll stick to this slide now. And so this enhances, again, a little bit further detail. So once you've had your triage, what next? And then this is where, for us, we would say safety first. So make sure your hands are clean, make sure you're wearing some personal protective equipment, make sure the environment that you're receiving the patient is clean as well. And this is why this idea of integrated care becomes important. If there is any difference between, the ability to have pre-hospital warning And that's amazing, right? Because if someone can alert you in advance that someone ill is coming in and you're worried about them, you can almost prepare your area better. And so this is the importance of having a pre-hospital setup as well, whether that be formal or informal. So airway, first thing again, check for any obstructions, check for movement into the lungs. So you're checking the trachea. And you'll be listening for things like stridor, so obstructed airway, which again might be an infectious cause. Could be epiglottitis, it could be tonsillar abscess, etc. So you might pick up signs of your focus of infection, but again, from a clinical management perspective, you don't really move away from the airway if you've got any concerns about it, because that means you have to get help. Either it has to be an intubation or a front and neck access if there's an obstructed airway with the appropriate people involved. In most cases, for general sepsis patients, this isn't an immediate issue. Unless they are profoundly unwell, unconscious, and therefore protection of the airway becomes an issue, in which case you can maybe temporize this with an oropharyngeal airway prior to formal airway management. Breathing. So ensure there's adequate movement into air and lungs. If they're, and this is the time again, they'll almost parallel assessment and interventions. So you'd put some oxygen on at this stage itself. And if again, the patient is unable to ventilate themselves, do think about assisted ventilation. So this might not mean going straight to a mechanical ventilator. This might be temporizing the situation with someone doing bag valve mask ventilation so you can move to the next bit. Now, this is where I think I really want to focus on the circulation bit here, because this is a priority from a sepsis perspective. So really assessing whether there's adequate perfusion. Is there enough oxygen getting to the tissues? And therefore, you're limiting this end organ dysfunction and the shock element. And again, obtaining intravenous access and administering treatments, which again, we'll focus on the next slide. And then disability, so trying to preserve brain functions. When you have to then examine the rest of the body, make sure we're not missing any wounds as an obvious focus of infection that need a washout or a surgical debridement, rashes that might indicate an overwhelming septic process, or any other environmental threats that are occurring. So hyperthermia or hypothermia, obviously not relevant to Yemen in the same way, but yeah. Next slide, please. So linked to that A2E approach, we'll often talk about signs and symptoms. And allergies, medications, past medical history, last oral intake, and events around the injury or illness. And this is the idea of a very short, structured history rather than a full-blown history. Again, we'll have time to do that later on once we've made our initial assessment of how well or unwell this patient is. So these are, a short bit of background around the patient and our concerns to help, again, confirm, is there infection underneath all of this? And trying to really understand the progression of the disease. So this has been a few days. Is that why we're now seeing a really unwell patient because it had fever for 4 or 5 days, and now sepsis is now setting in as that body's immune response? Because again, remember, infection and sepsis don't occur exactly at the same time. You'll get an infection, you'll start to fight the infection, and then your body's overwhelming immune response will take over, causing harm. Next slide, please. So we've already talked about the A and the B bit. And this is where I wanted to kind of just emphasize the circulation element. And this, again, is this idea of almost simultaneous interventions, where fluid is one of them. As strange as it sounds, basic fluid management is going to be your first element of treatment. So while you get IV access, you need to make sure you try, if you can, get a blood gas to check your sugar and lactate. And I would say in our practice, this is probably the most useful blood test that we do to decide if someone is well or unwell. So getting your pH, your bicarb, your base excess, your lactate and your glucose. And we make a huge amount of decision-making around well or unwell patients based on that blood gas. And then a blood culture. And that means you can get targeted antibiotic therapy in a few days. I would say that the rest of the bloods, although we do them routinely, so full blood count, CRP, very non-specific, a normal CRP and a normal full blood count does not exclude sepsis. Makes it less likely, but if you've got a really sick patient, it's hard to know how relevant that is. Sometimes you got to judge the patient, not the result. Procalcitonin, yes, much more sensitive and specific for bacterial infection. Pretty expensive test, not available all the time. Even for us in the UK, we're only allowed to use it in targeted patients, and we don't use it in A&E that often. Because again, you're not going to get the result in time to make a decision around whether you treat them for sepsis. Urea and electrolytes and creatinine, again, looking for signs of end organ injury from a kidney perspective. LFTs, again, coagulopathies, a sign of liver dysfunction as part of sepsis. But as I said, you're getting your IV access. Yes, you're getting these bloods taken, particularly the blood gas if possible. And if you don't have blood gas accessible yet, I think this is a key thing to say, well, how do we measure lactate, blood gas, and glucose, just as part of general assessment of critical acuity? And then you have to administer some fluids. Pretty simple stuff. Crystalloids at normal saline, Hartmann's, 500 ml bolus over 5 to 10 minutes. In children, 5 to 10 mils of fluid. We often recommend 10 mils, but there should be adjustments for lower volume if you've got high-risk groups. And I think this is where, because we don't have the evidence, it's hard to know specifically. I would suggest that in low middle income settings to consider a 5 mil per kilo bolus first to see how the patient reacts, and then repeat it up to a 10 mil bolus. So again, this kind of intervention, review, monitor, and cycle. The risk is if we give a large volume of fluid in children, the risk of pulmonary edema can sometimes be a little bit higher. And there's some evidence to say that in children with concurrent other pathologies or malaria or malnutrition, that there might be some complications linked to that. Similarly, in babies up to 28 days old, we tend to give 10 to 20 mils per kilo crystalloid. And again, I suggest probably giving a 10 mil per kilo bolus first, look at the response, and then move forward. Next slide, please. So linked to the IV fluids, early antibiotic administration is critical here. So if there's evidence of septic shock, so this is trying to decide, is that when you assess the patient, do they look hypoperfused? Are they confused because there's not enough blood getting to their brain? Is their skin cold? Can you not get a capillary refill? Is the blood pressure, the mean arterial blood pressure less than 65? Is the lactate up if you have an access to a lactate? Are they acidotic? In these cases, septic shock, aggressive IV fluids, and antibiotics within an hour. So this is our goals of care, that in that initial management, you've triaged them, you recognize they're unwell, fluids and antibiotics within an hour. If we know they're septic, maybe not critically unwell, we still have to prioritize it, but we're looking for within 3 hours, ideally. And this would ideally be IV antibiotics as opposed to oral. If you're really struggling with IV access, then IM antibiotics, or let's say you're transferring from a pre-hospital area, IM antibiotics might be the way to go in this. I think it tends to be broad spectrum in the first instance, and then you adjust that treatment as we move forward. Always doing monitoring as we go along, so monitoring vital signs, urine output, repeat blood gas and lactate if possible, targeted investigation, so roles for chest x-ray or urinalysis or CT scans or ultrasound or whatever it might be, that helps to confirm your suspicion that there's an infection underlying all of this. Don't forget maintenance, because again, yes, you're resuscitating with extra fluids, but you have to make sure there's a maintenance amount going through as well, and that'll be about 25 to 30 mils per kilo per day. And again, amend antibiotics or interventions as needed. Next slide, please. Now, I don't want you to focus on this too much. The references are there, but this comes from a particular score that was developed mainly for critical care, called the SOFA score, so the Sequential Organ Failure Assessment Score. The main reason I wanted to kind of bring this up is that it shows the requirement for other tests to help guide on how unwell a patient is. Interestingly, most of the international guidance don't recommend using this score in isolation. And I think here, for me, is a lesson. When you start reading about sepsis, you'll find all sorts of different terminology and scores that are available. But I don't think any of these scores have been really validated in isolation for use in global settings. And so I would caution against, again, copy-pasting a single tool. But again, I wanted to highlight this to you because you might come across it when you're doing your own self-directed learning around sepsis and septic shock. There's another score called a Q-SOFA score, which is meant to be the quick SOFA score, because actually when they published this, there was a lot of criticism saying, in many acute settings, we don't have access to all those blood tests yet, so we can't make a decision on acuity and rapidity of intervention. And so they looked at respiratory rate, conscious level, and I think blood pressure as other metrics, but again, very non-specific stuff. So I think having that standardized triage approach and the standardized way of recognizing someone who's critically ill in a designated area to support your decision-making is probably more helpful from an emergency care perspective. Next slide, please. So some things just reflect upon from a local perspective. So high income approaches cannot be transposed directly. And I really want to caution about this copy and paste approach that sometimes occurs, because we just don't know from an evidence-based practice, does that really make a difference, across the general population? How do we make sure we're not preventing harm? How do we make sure that a high income intervention such as intravenous fluids or antibiotics for conditions that are very different in terms of their pathology? I think we just moved back a slide. If we can move forward again. There we go. Brilliant. Thank you. How do we make sure that our treatments are appropriate? So clinical judgment is going to be really important, and acknowledging your resources and managing those resources effectively are going to be a priority to improve outcomes. Need to think about implementing infection prevention control measures right from the outset. And I think this again goes to say that we can't have good sepsis management if we're not actually thinking, particularly in our clinical environments, if we're not maintaining infection prevention control. And again, there's a link to community elements here as well. What are we doing about hand hygiene and health promotion at a community level that might prevent those diarrheal illnesses, which might then cause sepsis? So we need to think about that whole system and the determinants of health. Training for healthcare workers, community health workers is going to be vital. And again, although recognizing sepsis as a condition is important, I think also training people to have that overarching view of what is well or unwell becomes important from multiple causes. And there's some key things here from an emergency side, right? So difficulty breathing, injury, altered mental status, evidence of shock and hypoperfusion and confusion. These are going to be some key things to think about. Checklists and standardized care are going to be very important to improve the way we do things, and more importantly, minimizes error between practitioners. And it means we can create registries and research and genuinely look at the impact of our care. Often we think as an individual clinician that we're doing a great job. What you'll find is if you look back over a case series of a number of records that maybe you've intervened with, you'll say, oh, there might have been a few things I could do differently or do better. So collecting data, understanding what are the pathways, what are our preferences as practitioners, and how do we vary, and what interventions work is again important. Next slide, please. So last slide, pretty much for your key attention here. It's a medical emergency, sepsis. We need to prioritize the assessment for us to identify it, and then prioritize fluids and antibiotics. There are some significant challenges within limited resource settings when we think about infrastructure in order to do this, and how do we manage our resources sensitively, particularly in a public system. And training of multiple healthcare workers, cadres of healthcare workers, so not just physicians, but what are the role of other healthcare workers in improving sepsis outcome. I think it's really important that people across the change of the workforce are supported in their learning. And then research, quality improvement, innovation are all going to be critical aspects to improve our practice. And I think the next slide might be references, and that'll be it. So, yeah, so I think if the slides are being shared afterwards, there's a few bits of references that you can have a look at that includes links to the triage tool that we mentioned, as well as some of the basic emergency care course, I think, is linked in there as well, which is going to be referenced later on. So yeah, so I think we can probably close that. I think there's a couple of questions in the chat. Wahib, I'll let you guide me as to the next steps in the next few minutes, because I know I've overrun a little bit. I think you've got your next presentation coming up in a couple of minutes. Just looking at the questions, it says, how do signs of serious illness differ between adults or children based on triage? Oh yeah, so like we mentioned in the slides before the triage diagram, kids behave differently to adults. They often don't complain in the same way. They might present with vomiting. They might present with just altered behavior. So we're quite more sensitive based on their signs and symptoms. But obviously the vital signs range is going to be very different. So a young child's vital signs range are going to be very different to an adult, as well as a teenager or a 5 to 12-year-old kid. So the main thing on the triage scores are going to be around the thresholds for vital signs, as well as some of the symptoms. And the next one, the acronym SAMPLE. Yeah, so the SAMPLE approach is like a pre-hospital approach to taking a medical history. So signs and symptoms, allergies, what medications they're on, very briefly kind of past medical history, and then when they last ate, because again, if someone's critically unwell, then you have to intubate them or take them to theater, knowing their anesthetic risk will be important, and the exposure. So what exactly has happened as part of the signs and symptoms. So again, it's just trying to structure a way that we're not going through our very classical biomedical history where you take a long history of presenting complaint, you explore the family history, some genetics, and go through the whole pharmaceutical list. When someone's critically unwell, you don't often have time to do that, and neither should you have time to do that, because again, we're trying to get fluids and antibiotics done within an hour. And that's, from the time that you begin to think someone is septic. So if you're then spending 10, 15 minutes to try and figure out what's going on, and then it takes another half an hour to get your IV access, and then, to get your antibiotics drawn up, suddenly you're delaying things. So this idea of a golden hour of treatment is really important when you identify someone who's critically unwell, particularly from overwhelming infection. Hope that helps to answer those two questions.
Hello. Thank you, Dr. Najib. It was an excellent talk. And sorry, I was wondering if most of the research on sepsis the data is from high-income countries. So how practical is that research for Yemen and similar countries?
Yeah, no, absolutely. I think this is we're in a catch-22 situation, right? So we don't yet have enough research capacity in a range of low middle income countries. So Yemen is one of them, but many other settings are very similar, where we're not just generating the research. And there was a very interesting study from quite a while ago. It was a bit of a flawed study, but it was called, I think, the FEAST trial, which looked at intravenous fluids and infection in kids. And although it was a flawed study, it was multi-country, and they noticed that the fluid bolus they were giving in high-income countries, when they were giving them, I think it was in children in Kenya, mortality increased with the same fluid bolus. And again, there was some methodological weakness to the paper, but I think it demonstrated that there's variations in outcome that we can't predict for. And if we think about the Yemeni community, very different disease burden. And so even things like fluids and antibiotics, I would argue we don't yet 100% know the full impact. At the same time, it's our best guess. So, as physicians, we often have to use what tools are available. And so I think we have to say, okay, what do we understand about the disease process? What do we think might work as an intervention? Recognizing there's a time-critical element decision-making. And so I think for us as practitioners, we have to say, how are we collecting data internally? We might not need to have high-end research institutions, but even within a department, can we have, for example, a monthly meeting with our colleagues, say, we've had, how many cases of infection did we have? How do you think they went? Did they behave the way we thought? Or did something not quite work? Particularly if you've instituted a new policy or a new intervention saying, I now want all kids below a certain age to get this amount of fluid, or I want all treatments, you modified a practice and you're monitoring it as a system. I think we have to start professionalizing our data gathering as part of a system approach for emergency care.
Yes, thank you. I think that is the key message, that understanding our local data, especially in the lower and less developed countries, and then taking it from there. Thank you. And just another quick question about: do you think lymphopenia is more relevant than neutrophilia in these?
So again, if I speak very bluntly as an emergency medicine consultant, it makes no difference to me in that first stage. And by the time, we sometimes, it takes, subhanAllah, you might think high income setting, but it can take us sometimes 5-6 hours to get our labs back. So by that time, the patient might have moved out from our ED setting onto the ward. I think, again, for me, the lactate and elevated lactate and signs of acidosis are going to be the key markers here for acuity and unwellness. I think if there's neutropenia, that is very concerning. As a vulnerability, either as a consumptive process of major infection, or a high vulnerability risk, being the body's not going to mount an adequate response. And I would say lymphopenia is similar. So if you see profound changes in your white cell count differentials, this has got to trigger, okay, are we dealing with something different? An expected response would be a high neutrophilia. So that just confirms our suspicion. A low neutrophil count or a low lymphocyte count almost makes me more concerned. are we still treating what we think we're dealing with? Is this patient more unwell than we previously assumed? And do we need to broaden our scope as to whether there's a different pathology, so non-bacterial drivers for sepsis? Because again, the infection could be helminthic, it could be fungal, could be viral. So I think this is, again, what we don't yet know from non-high income settings is the pathogenesis of sepsis going to be the same for these other classes of infection processes? Opportunity for learning.
Thank you. And I'm really interested by your answers. So can I take one or two more questions whilst we sort
well,
out?
Feel free. Yes.
Is that all right?
Yeah. I'm okay. As long as I don't take into other speakers' times, I'm absolutely fine. Yes.
I think we are still waiting for our next speaker. So
okay.
it would be good to get your insight on what advice would you give for those areas where, say, perhaps there is no doctor, any role for non-doctors in early recognition and management?
Yeah, so I think this is going to be essential. And I think in many settings, we have seen the critical role that community health workers play in managing that pre-hospital setup. Now, there's something which some colleagues might be familiar with called the 3 delays model. This was used in maternal health over the last 20 years or so. And, this is when still a lot of global health was vertically minded in terms of improving outcomes. So they knew maternal mortality was a big problem, so they focused on maternal health. And the 3 delays model talks about an initial delay in recognizing a complicated labor. When they recognize it, there's a delay to transfer to a facility. When they get to a facility, there's a delay to get the appropriate treatment. And this all contributed to bad outcomes in maternal health. A lot of the improvements have been based on improving an understanding of complicated maternal health at a community level, whether it be community midwives or traditional birth attendants, etc., who are seeing these women saying, oh, I think you've got a problem labor or a problem pregnancy. Let's get you to a facility quicker. And you're training healthcare staff at the facility to be able to receive such a patient. I would say the same analogy works across the emergency care spectrum. And so sepsis would be one of them. So if we can sensitize lay workers, even say, look, what does someone who looks unwell like? And what do you think an infection might be? So they say, oh, this person's had a cough for about a week, and now they're lying semi-comatose in the bed. It shouldn't be, oh, maybe they'll be better tomorrow. Give them some liquid and, fan them. Or something, that's where, like, okay, oh, it's malaria. We saw this before. They'll be better tomorrow. That's the case. Say, look, you can't accept that situation anymore. You have to get them to an appropriate facility quickly. Similarly for a child, if you might see someone says, oh, this child's not been feeding very well and the nappy's now dry. Oh, no, just try harder. You're just not trying hard enough. That's, again, where you almost have to over triage at a community level and then do the assessments in a facility. So definitely there's a role in raising sensitization, and community health workers or a similar cadre at a community level is going to be really vital.
Okay, thank you. And I would just take one last question. And if the IT issues, I think Professor Susanna is having some IT issues logging in. So if she's unable to join, I think we will have an early break. So just one last question before the break, really. So, in lower income countries, patients are often illiterate. So how do we know medications which affect management, say, for instance, metformin, could perhaps have caused the acidosis, and perhaps asking the patients to talk through their allergies. So how do we mitigate those challenges in lower income countries?
Sure. No, that's a really interesting question. And I think these are some of the challenges that need local expertise and local adaptation. So where's the role of other family members in helping to confirm things? And also, how important is it in the emergent setting? So basically, do you have time to pause that bit of information, intervene, and then recollect that later? Again, from a practical perspective, when we get patients that come in a critical state, it's very rare we can confirm the full cohort of their medications. And in reality, okay, if they are acidotic, is that going to be a full contributor for the full acuity of their health, right? Again, if the acidosis is represented by organ dysfunction, then it almost doesn't matter if it's metformin on its own or in combination with infection, etc. And I think this is modern healthcare. Modern healthcare, patients will have multimorbid presenting scenarios, but the key message is here, regardless of that cause, if you suspect someone is critically unwell and you suspect infection as part of that driver, you treat them anyway.
Yes.
And then you reassessments and monitoring. So in that, and you know, a very elderly population department, we will probably get at least one phone call every hour to probably at least every hour from the ambulance crew saying suspected red flag sepsis. And this will be in an 80-year-old patient from a nursing home who's just confused for a couple of days, reduce urine output, maybe a fever. And then they'll bring them in. We'll get the IV access. We'll confirm if their lactate is up or if they're clinically shut down. Give initial bolus of fluid. For elderly, we usually give 250 mils first rather than 500, and then review and some antibiotics. And then we kind of say, okay, let's now look at the notes. Let's corroborate the history. Let's call the relatives. Let's get this more information. So I think that similar approach can be assumed in this case. I don't think so I know we mentioned that sample history, trying to identify that. It provides a framework, but it doesn't mean you can't intervene while that's happening in parallel. And it might be you send someone off to get that information later on, but it doesn't prevent you from instituting or intravenous access in your fluids because you see that someone is unwell.
Okay, thank you very much. And we really appreciate your time, your thoughts, sharing your knowledge. It was, I'm pretty sure everybody in the audience would agree that we've gained more experience after listening to your talk. And thank you really very much for taking all the questions.
I just want to say there's a couple in the chat which, with your permission, I can very quickly scan through.
Yes.
And so I think there's something around antibiotic abuse and resistance. So this is a global issue, not just in Yemen, but we know that this is particularly bad in certain countries. And there is greater evidence being collected now in certain hospitals in Yemen, particularly around neonatal mortality. So I think this is going to be was meant to be one of the next lectures around late onset and early onset neonatal mortality. But if you look at sepsis in Yemen on a literature search for papers, you'll find that neonatal sepsis and antibiotic resistance is coming up as some of the new research areas. So yeah, I think this is where you do need some guidance and support as well. And then looking at compliance. So getting someone to issue a guidance, but then make sure people are complying with that guidance will be important. The other issue someone had mentioned was about IPC as a public health issue versus a facility issue. To us, the two go hand in hand. I think there's a lot of antimicrobial resistance is because of poor IPC management within our hospital care settings, where we're transferring colonized infections across an area or iatrogenic wounds, etc. So I think there is this importance to recognize that IPC as a global understanding has roles in multiple areas. So not just public health. And I'll let you guys go grab the coffee and I'll probably go do the same.
You're more than welcome to stay for the session, but I understand you're traveling, so I'll let you.
Yes, actually, my wife has just texted me, so I better go.
Thank you very much. Take care.
Okay, inshallah. Okay, take care. Assalamu alaikum, everyone. Have a good rest of the day.
All right. So for our speakers, it looks like Professor Susanna is having some IT issues and has not been able to join us yet. We will try to put her talk, if she's able to join later on, that's all right. Otherwise, we will get a recorded session and upload it on the YouTube recording. So shall we call it a break now? So let's go for an early break and we will be back for a talk by Dr. Joe Bonney. So it's nearly 10:15 now in the UK. So if we take a 15 minutes break and if we are back by 11, that should be all right with everyone. And I think the Yemen time is we will be back by 1 for the local Yemen time. Thank you. Hello and welcome back, everyone. I hope we all had a quick break. Let's get back on track. I'm pleased to introduce Dr. Joseph Boni, who is our next speaker. Dr. Boni is the president for the African Federation for Emergency Medicine. He holds a master's in public health and a master's degree in disaster medicine and is currently pursuing a PhD in disaster medicine. Dr. Boni is currently an emergency medicine specialist at the Komfo Onoki Teaching Hospital. He is a founding member of the Emergency Medicine Society of Ghana and also a member of several other task force. He serves as an editor for several journals, including Ghana Medical, African Journal for Emergency Medicine, and the Global Emergency Medicine Literature Review. With no further delay, I invite Dr. Boni to deliver his talk. We're looking forward to the talk, Dr. Boni.
Right,
Welcome.
thank you very much. Can you confirm you can see my screen?
Yes, we can. Thank you.
And also confirm you can see me.
Yes, of course. Yes.
Hello, and thank you for the great honor to be able to present across the world today. I'm very happy to hear about the content of the conference, and I greatly enjoyed the talk just before the break time. I'll quickly move on. So my presentation will be centered on scaling basic emergency care for timely resuscitation of sepsis. I will take a little time to give a brief talk about what the basic emergency care is and look at what point this becomes relevant for sepsis management. So I have a lot of affiliations, but no conflicts of interest to declare. So the African Sepsis Alliance, and I am sure this will be similar to almost a lot of places around the world, says that at least 2 million sepsis deaths are estimated to occur in the African region. And this can be extrapolated to other low and middle income countries. And sepsis is the third biggest cause of maternal mortality. And then the third maternal mortality deaths in Africa, having the highest rates of sepsis. And a real financial burden, not just in the African continent, but across the world, how much efforts and resources are spent on sepsis management. So with all of this, it has become clear that we need a solution, and we need a solution that is not too expensive, and a solution that we're all assured will work. So in a work done by Dr. Tegan Lucas and myself in Ghana, looking at how do people with acute infections end up in facilities in Ghana, we realized that the days between the first symptom and the initial home care, a lot of people decided to start home remedies. And I'm sure this is also something that we will find in most places in the world. But almost half of the people started home care on the first day. But interestingly, the treatments started at home were quite varied, where almost 35% of them started on known medication. So my brother or sister or my wife or my husband got this medicine and it seemed to work. I don't know the name, so let me just continue what was left of their prescription. Paracetamol seemed to be for 20%, herbs for almost 8%. Antimalarials, if you're in a region where there's malaria, accounted for 5.1%. And then antibiotics for almost 5%. And this is unwarranted, untested. We had no idea what the patients had or did not have. I got a message that there's an echo. Can we confirm it's better now?
I did not have any echo, so I don't know whether it is on the participant's end.
Okay, all right, excellent, thank you. So Then we looked at how do people get to the hospital? How many facilities do they visit before they get to the hospital? So almost 62% of all our participants went straight to a hospital. They did not go to one other facility or two other facilities or three other facilities before they ended up in the hospital that they were being managed, where we're picking up the data. And we looked at a time from the first symptom to the first hospital, and it was clear that a good number were happy to present in less than a day, which is 35%. And if you pick day 1 to day 2 and you put that together, it means more than half of the people were happy to go to the hospital in about a day when they started experiencing their first symptom. Using the WHO framework, we looked at the various patterns of care. So the scene. So the scene can be home, it can be your hospital, it can be wherever we think is the first point of care the person is receiving. The bystanders and the healthcare providers are the ones that provide this first care. And we're hoping that patients are transferred with an ambulance to a final hospital destination. But this is not the case we see among a lot of cases. So if you have the individual will go and seek spiritual healing, will go to a pharmacy or herbal shop, will then go to a hospital, come back home. When it's getting worse, that's when they rush to an emergency department. Sometimes emergency departments will say, well, you're not sick enough, we'll send you back home. And the cycle becomes very confusing, and the healthcare they need is not being provided at a point. Let's remember that all of these people presented to the hospital, half of them presented to the hospital a day after they had their first symptom. So really, building the capacity for sepsis management at all levels is really essential, because it will help to build the activities, and wherever facility the person ends up in, he will be able to get good care for sepsis management. And this includes a lot of activities. There can be training, there will be self-learning or some learning approaches. The knowledge gain will translate into skill. There can be coaching from senior mentors and on events like this. There can be support and then further development. So a diagram like what we have here indicates some of the self-learning approaches, where these posters can be placed on a ward to remind people that if somebody presents with shivers, extreme pain, pale, sleepy, feeling like they might die, shortness of breath, these are the kind of people that you should consider sepsis in. In all of this, and keeping this very simple, the WHO Academy, the WHO, the ICRC, and International Federation for Emergency Medicine came together to develop a course which is called the Basic Emergency Care Course. The idea of this course is to be able to have people go through a basic emergency training, but this level of training will be applicable to various cases. And in this case, we're going to look at it in relation to sepsis. So this has been implemented in over 60 countries and has been found applicable in diverse settings around the world, where we've seen this held in high-income countries and also in very remote areas of care. The aim of this course is to ensure that the first contact healthcare worker has the capacity to provide quality care using a standardized approach of recognition and management of emergency conditions. And the objectives are to provide a systematic approach, just like we've seen in those that have done BLS, ACLS, ATLS. The basic emergency care course also gives you a systematic approach to see the patient and understand how to give a handover to a higher facility when you do not have the resources to manage the patient. So this is how the content is approached into 5 different models of airway, breathing, circulation, disability, and exposure being the approach, but having the models of trauma, shock, difficulty in breathing, altered mental status, handover, and medications as the main approaches. BEC is for everyone, the whole emergency care team. So it's not just the doctors that need this, it's not just the nurses, but easily can this be promoted in schools, among our ambulance providers, mid-level healthcare workers who all attend to patients. An understanding of this basic concept allows you to be able to translate the care within the focus. So I will use the African Federation as an example for how you can scale up BEC. But these tips can be applied to any setting around the world to scale up BEC. The basic emergency care course is in a structure of this nature. It's a 4 to 5 days in-person course, after which you become a trained provider. If you do a 1 to 2 day training of trainers, you then become a provisional facilitator. And then when you teach BEC under supervision of a master trainer, you become a registered facilitator. If you teach 2 more, you then become a master facilitator and then can go on to promote BEC wherever you are in your region. This is the map of Africa showing the number of courses that have been run in countries. And you can see we have quite a chunk of Northern Africa that are still blank without courses that have been run. But also, interestingly, you can see in East Africa where a country has 162 courses that have been run. And this is because they were one of the first to start basic emergency care, and they've had good resources and country support to continue to promote this. If you look at 2015 through to 2024, you can see a really big spike between 2019 and 2020, where COVID showed that the provision of basic emergency care course can handle conditions, a lot of conditions, including sepsis, including COVID-19. So where lots of interest came in training providers, even training provisional and master trainers, all soared up a little. And we're very happy to say that a big chunk of this number, which is in red, are nurses. So we have more nurses trained in basic emergency care, as in some facilities, you would only be seen by a nurse first. These numbers are quite clear here, with 8,464, as at the time I had this data, which is about 2 months ago, to show that there has been really great strength in training, and this can be replicated around the world. So this gives you a couple of pictures of a training that occurred in one of our facilities. But doing more for all for sepsis, how do we then think about basic emergency care in the approach for sepsis? So what are the challenges that we face? Lack of training equipment. When we want to run training for people, we have big lack of training equipment. We also have taking healthcare workers out of their practice, making it very difficult for them to be able to take a whole 5 days to do basic emergency care course and 2 more days for a trainer of trainers. And then the knowledge transfer and sustainability will need to be maintained. Based on this, there have been some approaches to help mitigate these challenges. The first one is moving from the classic basic emergency care course to the hybrid basic emergency care course. And this hybrid is now available online on the WHO Academy for you to complete one section of the basic emergency care course. And all you will need will be 2 days of practical training to be done with the course. So this is an example of a self-paced WHO Academy basic emergency care course and a 2-day in-person face-to-face where lots of practical sessions are held. The self-paced goes through the exact formula of the in-person, making it very accessible. And this is how the 2-day in-person will look like. Concentrating on the small group discussions to bring the understanding and group discussions out, and the practical scenarios for people to be able to gain the skills for this. Also, in partnership with LADO, WHO, the African Federation of Emergency Medicine, and the International Federation for Emergency Medicine worked on developing a tool that allows you to have very simple kits ready to be able to train at any parts of the world. And this was called the Portable Emergency Care Learning Lab. And this was supposed to support the 25-25 approach of training 25 countries, 25% of all nurses in countries in 2025. And it'll be interesting to know if Yemen is one of these countries that is doing this. So a fast track and collaborative approach, we looked at this, and this is a picture of me standing in the far right with Terry Ronalds, who is the head of emergency and critical care services. And on the far left is the chief nursing officer of the WHO. And we're looking at which approaches would help us to be able to work on this well, to understand how to create a good tool. So this tool has now been tested in all of these countries that are marked green. So in India, in the UAE, in Mali, Niger, Sudan, South Africa, and some places in South America, to be able to tell us, do these tools work? Also, it's low cost, 90% of any alternative. And as you can see from the picture here, these are portable enough to carry in your backpack or drop in the cabin of an airplane or carry in the back of your car trunk to be able to train people. These are examples of the field testing that has been done. And the quote is that it has transformed the teaching for one of our nursing professors in South Africa. So this shows a trainer of trainers of how to do the courses and how to run the courses using the portable toolkits. So the next step is to look at being able to allow the facilities to train on their own. How do we get people to do high-frequency refresher trainings in their hospitals, focusing on whichever disease entity? So if today we're picking sepsis, how would you manage the sepsis patients using the ABCD approach for management? And if you think you can't handle it, at what points do you hand over? Africa has been able to have a success story of scaling basic emergency care course in managing conditions, especially sepsis, with 8,000 people. And we're hoping that the lesson learned can be translated into lots of countries around the world, especially for us today in Yemen, to be able to promote care. So thank you very much, and I'm happy to take questions, comments, and contributions.
Thank you very much. That was really interesting, and it was more. Some of the stuff was new to me as well. The core modules, very nice approach. Thank you very much. I think we have a question from our from one of the participants saying BEC is a fascinating approach for lower and middle income countries. What is your advice to replicate your experience in other facility contexts outside Africa?
Right. Thank you very much. And I was expecting this question just based on the fact that we presented what is in Africa, how do we move this to other places around the world? The basic emergency care course is supported by the WHO. And now with the online platform, you can have a lot of your team members complete the online platform. It's free, it is self-paced, so that doesn't require any level of implementation. You will, however, require some support from the WHO, and I will share the email addresses of the people that you can contact at the HQ to do this. But also, cascading down, your regional offices and your country office in Yemen should be able to give you an approach. So whether you're in Yemen or in any other country, your country office for your country office for WHO already has a platform for how to scale up. The only question that comes in will be how much funding you can pull in and how many people you can train. But if you are proposing to your Ministry of Health or your health service that instead of a 5-day, we've got maybe 50 people that have completed their online courses, they only need to do a 2-day, we only need to bring in one master trainer who can do some multiple sessions or a couple of trainers that can do multiple sessions. And then afterwards, we can have the capacity to cascade it usually sells a really good story where it's not like some of the other training courses that will expire and you would need to pay lots of money to renew, or it costs you so much to run the course and cascading the course becomes difficult. In this case, the minute you are able to have your own master trainers, you can run the course easily in your hospital's lecture room without too much resources. When it's lunchtime, everybody can go for lunch, come back to the room that you're not paying for. Facilitators are part of the hospital, and it really cuts down the cost. The initial approach will be a little bit more budget heavy, where you might need to fly in some trainers to support get you to this level. But contact your country offices, contact the WHO emergency care office, and they will be able to help you. I will put their email in the chat room very soon, so that we can all know how we're able to reach them and to move this forward. So I have put the CSY, which is the group at WHO that manages basic emergency care course, in the chat room to be able to provide support if anybody needs it. And also the African Federation for Emergency Medicine is also happy to lend a hand to any country who wants to set this up. With our years of experience, we will be able to support greatly and provide some advice. Although this is outside our region, we really don't depend on our regions. We're happy to support any country that wants to do basic emergency care course. So I've also put the email address for our programs office in the chat. So you can always copy us in any email you're sending and we can provide some support. Thank you.
Thank you very much. I should admit that I love Ghana. It embodies so much hope for other countries. Thank you. Can I check, in Ghana, how do sepsis outcomes in rural areas compared to those in urban areas? Do you think this can be replicated in other low-income countries like Yemen?
So we probably might be sharing the same problems, and maybe we should be aiming at working together for same solutions. The referral policy system in these places become a little difficult. The health-seeking behavior is the other arm. So let me speak a little about both of them. The health-seeking behavior prevents us from being able to catch the infections early for a lot of patients. For the work that we did, interestingly, we're speaking to patients that were in the hospital. I am sure our percentages of numbers of people that will attend hospitals might quickly change if we did a community survey. And so a lot of the people that might come, even if they are presenting early, are presenting with quite severe complications of sepsis. And it's at the point where they can't handle it anymore. That's when they end up in the hospitals. With not so much broad spread training for recognition, some of this is not recognized early, even if they're in a lower health facility in a rural area. And even when it is recognized, the transfer to a higher facility, which is always overburdened and overcrowded, becomes a little hindrance. So the trick has been for the trainings to cascade down so that fewer patients with sepsis are being moved towards the advanced facilities if they don't need that level of care, so that only those that need the level of care will have the availability. This is truly work in progress, and it is difficult. It requires lots of stakeholder engagement, but some work is being done on developing a new version of the referral policy document. And with that, we're hoping that the implementation of that can support sepsis care. In any case, the passive education for sepsis has really grown, where there are a couple of webinars once in a while, and there are some posters that can be distributed to hospitals to help them to understand this.
Thank you. I think another participant has a question on, are you doing pre and post assessment for the trainees?
Yes. So there is a pre-test and a post-test, and then it's a pre-course a self-assessment for you to tell us where do you think you are. And after the course, you would review it and say, well, I think I've learned something, or maybe I've not learned anything. But it's a pre and post-test, and then there's a assessment before and after, and then also an evaluation when we're done for you to advise on how the course can be improved.
Okay, thank you. Another question really is about the differences in income disparities. So do you think, is there a lot of effect from income disparities and sepsis outcomes in Ghana and perhaps other countries like Yemen?
There's no two ways about that. Just the level of resources available to you even in one country where it is urban, peri-urban, and rural, just the level of resources to you makes a big difference. But we should always realize that the biggest resource in the healthcare sector is the healthcare workers themselves. And the capacity to train them is not as hefty as a new ventilator or a high flow oxygen or a new ICU bed and so on. So that cost disparity can be balanced out slightly if we're able to improve the capacity and the recognition to move the patients early. The cost differences always makes a difference in how much more you can do, which services are available, and when they're not available and the patient requires to move up, that level of recognition from capacity building from health workers is what should help bridge this gap. We cannot have all hospitals being at the highest level in our facilities, but we can have our healthcare workers recognize when they've reached the level that they are and move the patients quickly.
Thank you. I think we have another participant asking if, do you have any published papers that show the impact of such training on morbidity and mortality?
So I am quickly searching for this in here, but if I do find it, I will share it. If not, I will share with the organizers to send to the participants. But there is a landmark paper from Uganda that showed that implementing some of the basic emergency care tools led to a reduction of more than 50% in the mortality in that region. So it was not just basic emergency care course. There were a few other emergency medicine care tools that were used, but all of this led to the reduction of mortalities by almost 50%. I will share the link to all the emergency care tools in the chat room. I'm doing that now.
That's all right. Thank you.
Great.
And can I check how necessary do you think is multidisciplinary team working in managing sepsis? For instance, how much do we need to train the nurses more? So do we prioritize focusing the nursing training as part of an MDT approach?
The answer is quite obvious from how we have approached it, where we have targeted nurses as the ones that are by the patient side. It's known, and as much as doctors we would not admit, the nurses will always get way more information than we will. They will get all the side information that a patient or a patient relative sometimes is a little too afraid or shy to tell the doctor about the herbal treatments they have done or the churches they've been to, but they might be a little more open to a nurse. And if this allows them to get a little more information, to focus their attention on what can I recognize as an emergency for this patient, then it means that that level of multi-approach is really important. We're not taking out the rest of the healthcare workers, our laboratory staff, our records who would help us trace a patient back to their home if necessary, and so on. But the multidisciplinary approach, even across the healthcare clinicians themselves, not just emergency, but in involvement of obstetricians, involvement of internal medicine, trauma, because we will conclude somebody was involved in an RTA, a road traffic accident or a road traffic emergency. But what is actually his problem now is the open wound that is being infected, leading to sepsis. So they should recognize that if I need help from somebody that understands sepsis a little more, we should have that interconnectivity there. But ensuring that it's not only doctors at the table, we have all our cadres of staff to be able to support. But reiterating, nursing training is at the heart of being able to promote emergency care.
Thank you very much. I think that is one of the key messages to highlight focus on nursing training. I think we are nearly due for the next talk, so maybe just one last question before we move on. Conditions like malaria and dengue may present similar to bacterial sepsis. So how do you advise that the right treatment is given early on, especially if at the point of testing, we don't have tests that are sensitive or specific enough?
So you've taken the answer out by removing the testing. The idea about epidemiology can also help. If you do recognize that this is a dengue season, then you will have a little more suspicion of dengue within that period. Malaria presents a really unique condition, and as it has so many symptoms that could mimic sepsis presentation, dengue presentation, and other really non-specific presentations where you can have a patient who has malaria and only the abdominal symptoms are what are prominent. The introductions of bedside RDT kits, which are cheap, available, and even in some countries supported by WHO and are made free to hospitals, can help you differentiate between a malaria and something else. In the case of doubt, if you are able to do a simple full blood count for your white cell count, if it's elevated, then you can think about sepsis, or a careful history to be able to say, I have evidence of some form of infection seeding. So cough with signs on the chest that are suggestive of a pneumonia, cloudy urine suggestive of a UTI, you would really need to go back to the basics if you have no labs to be able to do your clinical examination and some bedside testing that is available to you to be able to help determine. I'd like to just take 1 minute to show you the WHO Emergency Care Toolkits page. And it's really interesting. The first thing that you see is a basic emergency care. And if you go through here, you will be able to find access to the online course. But there are also triage tools, how to design a resuscitation area, and simple emergency care checklist. And then standardized forms and WHO registries. So if anybody is interested in using any of these tools, the emails that I had provided, please write to us, copy both of us, and we'll be able to assist in moving things forward. And then also tools for referral and counter-referral. Acute transfer checklist, acute referral forms, counter-referral forms, and so on. And other tools that are available. So emergency care pocket guide. So I will challenge everybody to download this copy today and share with their healthcare workers on their social media platforms, if it's WhatsApp or so. And then medical and trauma resuscitation algorithm. For our talk here, the medical resuscitation algorithm will be one of the things that I think will be crucial for us to have a look at, which just outlines what you will do for a patient when the patient arrives at the hospital using the ABCDE approach. And then it also just keeps reminding you about all the other tools that are available. And I think this will be a nice poster in a hospital, and you can just rebrand it and put a big sepsis on top and say, for sepsis management, we know this can help you follow a recognized approach. Thank you.
Thank you very much. And thank you for sharing all the links and the paper. It was a pleasure to have your talk. I think the participants agree as well with me. Thank you very much.
Thank you.
Thank you. Let's move on to our next speaker, who is Professor Niranjan Kisoon. I would say that a warm welcome to Professor Kisoon, who is unable to join us today, but has kindly shared his recording for the session. Professor Kisoon is the endowed chair for acute and critical global health at the University of British Columbia. He is also the past president of the World Federation of Pediatric Critical and Intensive Care Societies and professor of pediatrics and surgery at the Department of Pediatrics in University of British Columbia. He is the president of the Global Sepsis Alliance, and co-chair of the Pediatric Surviving Sepsis Campaign, as well as vice president of the Canadian Sepsis Foundation. He is additionally advisory board member for Sepsis Alliance USA and African Sepsis Alliance. So we look forward to the recorded talk, and please note that if we have questions on the chat, we will try to pass it on to the speaker and hopefully get them answered in the YouTube recording available later on after the conference. Thank you. Whilst we wait for the videos to be played, I'd like to remind participants that there will be breakout rooms during the sessions so that participants can interact with each other and the speakers if they're available during the break. Thank you. Shall we try to restart? Because it looks like we are not able to hear Professor Niranjan talking.
Patients. Now, what I'd like to address three issues in the next little while: the importance of the Phoenix criterion sepsis score. What is the Phoenix criterion score for sepsis, and how to use the Phoenix score in resource 4 areas. The first thing, why is it important, relates to the burden of pediatric sepsis. And we did this study published in 2020 in The Lancet that showed that there were approximately 21 or 22 million cases of pediatric sepsis globally, accounting for 40% of overall global sepsis burden. And obviously there were about 3.5 million deaths. Now, this is a tragedy in that many of these deaths are preventable. So the burden of sepsis is very high. The issue we face also is, what is sepsis? We know that children, there's a wide gradation of infections, from fever to someone having the flu, sniffles, runny nose, etc., to having sepsis and the extreme septic shock, which is the most extreme form and may result in death and disability. In the early stages, we need tests that we need to recognize sepsis early, and hence we need sensitive indicators, but we also need to be specific in the correct diagnosis. The fact is that in the late stages, sepsis is very easy to recognize, but very difficult to treat. And we see that the responsive to intervention increases until in septic shock, it may be very difficult, especially in an area like Yemen, where there are limited resources such as complex ventilation, pediatric ICU care, etc. Now, for years, we have used the International Pediatric Sepsis Consensus Conference definition to recognize sepsis, the so-called SIRS criteria. And the SIRS criteria, in fact, lists the major organ dysfunction: cardiovascular, respiratory, neurologic, renal, hepatic, etc. It's the only criteria to date for children, but it was not based on any evidence. It was evidence-based. It was not validated. SIRS in children, in fact, may not be maladaptive. And we now know that sepsis is a maladaptive response to an infection that leads to organ failure and dysfunction. There was inconsistent application by clinician and researchers, and it gave a wide range of sepsis burden. The adults' recognition of the need for sepsis diagnosis had the third International Consensus Definition Conference in 2016, in which they defined sepsis as a life-threatening organ dysfunction caused by a dysregulated host response to infection. The task force, they concentrated on adults, but they also recognized the need for pediatric population and the use of clinical criteria that takes age and different pathophysiological responses into consideration. So it was data-driven, which was an advance to what we had before, also with consensus. It's not for children. The data was derived from high-income countries only and used existing adult scores. Indeed, Pediatric Sepsis Task Force we formed in 2019 was an attempt to address the pediatric issues. The importance of the pediatric score is that we gain data from 6 higher and lower and 4 lower resource settings in many parts of the world, US, 1 from Africa. We also had from South Asia. Not totally what we wanted, but this was the data that was available. It had to be centers that had electronic health data, and it was 2010 to 2019. The strength of this project is we had a large cohort size. We had 3.6 million hospital encounters in children less than 18 years of age, whereas the adult had about 1.2 million. We had a development set of 3 million and an external validation set of 581,000. And as one can see, it excluded birth cohort less than 37 weeks. And these were patients we looked at infection in the first 24 hours of hospitalization. So when we decided to address this sepsis definition, we felt we needed to have an infection, suspected infection within 24 hours. The primary outcome was in-hospital mortality. And we looked at the best performing organ dysfunction components of all the existing scores. This is not very important, but I'm giving you a little background. And when we looked at the scores, we had the consensus definition, the PLOD score, the podium score, PROL, SOFA, DIC score, vasoactive score, and shock index. And we looked for this within these scores, the issues that was most related to high mortality, best predicted mortality in patients with infection versus non-infection. So, for instance, you will see the number of vasoactive agents that was used for cardiovascular score, lactate from the PLOD, and then we had, like, from the PSOFA and respiratory, we had scores, the SF ratio from there, and platelets, fibrinogen, etc. So it's important to know that these were the best scores we had previously. We now took those that were the elements of those scores that resulted in the highest mortality. We then translate that into a Phoenix sepsis score, and we chose the 4 organs after doing complex methodology and statistical analysis that showed respiratory, cardiovascular, coagulation, and neurologic were the highest predictors of mortality. And as one can see, we had 1 to 3 points for respiratory, 1, 2 for cardiovascular and coagulation, and different elements of it. And these can be found in the article that can be downloaded. Now, the total score that you can get is anywhere from 0 points to 13 points, so it's a wide range. And sepsis was defined as 2 points on the Phoenix score, and septic shock is sepsis and greater than or equal to one cardiovascular point. And the reason we chose those is also an international survey we did previously showed that many of these elements are collected in many areas in the world. So we built redundancy into the score such that even if you do not collect all the elements, you can still make a diagnosis of sepsis. And these are the 2 articles. As I said, they are downloadable from JAMA. They're open access, so can be widely available. So how do you use the Phoenix score in poor areas of the world? Well, one, the advantages of the Phoenix score is that it applies to all children, except birth hospitalizations and those less than 37 weeks, and it applies up to those to 17 years. It gets rid of the SIRS criterion, severe sepsis. It is life-threatening, suspected or confirmed infection. And as I said, septic shock has to have a cardiovascular component. The advantages of the Phoenix score is that the calibration is very good in both high and low resource settings. But I must say that when we think about high and low resource settings, remember these are settings that had ICUs and they had electronic medical records. So they are not truly low resource settings. I would think that they would be the best resource settings in these areas. And one can see here the development is the yellow, the internal validation and external validation. As the Phoenix score increases, in-hospital mortality increases. So with a Phoenix score of, say, 3, the mortality would be about 5 to 8%. And as we go 4, 5, or 6, the mortality increases to over 40%. And this is in the higher resource areas. If we look at Phoenix score in the other centers, the one in sub-Saharan Africa and Asia, we find that there is also a good calibration with the increase in Phoenix score and mortality. But one can see here, whereas a Phoenix score of 2 previously resulted in a mortality of 8%, it is now a mortality of 20%, demonstrating that where resources are less, the mortality is higher. So this was for us very reassuring to see that the Phoenix score works. Now, we had a lot of discussion about single organ sepsis, whether single organ respiratory or neurological dysfunction have sepsis. And what we found is that, yes, the Phoenix score without remote organ dysfunction, you can see the little blue rim, the mortality is 1.7%, whereas when there is a remote organ dysfunction, so for instance, if you have, let's say, respiratory sepsis and pneumonia and now have renal or cardiovascular dysfunction, the mortality is 8% in higher resource areas. Now, but however, the overall mortality is still 7%. So whereas you have, whether you have one organ dysfunction or multiple organ dysfunction, the Phoenix score works in both cases. And in most cases, in our experience, the patients had multiple organ dysfunction. In the low resource settings on your right, you can see the very same thing. Mortality is 6% for one organ dysfunction, the blue rim, and 32% for multi-organ dysfunction with an overall mortality of 28%. So in high-income countries, it's 7%. In low-income countries, it's 28%. But as I said, the vast number of cases is multi-organ. Now, so the Phoenix criterion resource poor areas, the data is derived, as I said, derived from centers that has ER and PICU and may not directly relate to the situation in Yemen. There is also difficulty in applying the definition of shock. Sort of blood pressure measurements in children are not measured routinely in many centers. Lactate are not measured routinely. Neither is inotropic support. The Phoenix score uses the Glasgow Coma scale, whereas in many places, the alert verbal pain and unresponsive scale is used, or the Blantyre scale. So we need to address interchangeability of and validation of criteria to use the Phoenix score in poor areas. Now, the Phoenix score predicts death from sepsis. And if you forget everything else I've said, it is important to realize it is not an early warning tool. It is not a screening tool. And what we have to do, the work that needs to be done, is to find ways to identify the children at high risk for developing sepsis. Those would be the majority of patients that would show up in physician's office or emergency department. So the Phoenix criteria cannot be used for that. Now, the Phoenix criteria in poor settings, It's the best we got. It provides a standard to track scores, monitor interventions, and standardize benchmark. It provides an inclusion criteria in research and outcome studies, and it also provides a common language for surveillance definitions and criteria. So it is a major step forward, and it is better than any of the previous scores we had, but it has limitation. The good news is there's growth of digitalization in many parts of poor countries in the world, both in sub-Saharan Africa and Asia. And this offers an innovation opportunity to innovate. Data for clinical care and policy agenda can be generated, metrics to compare economic indicators, which is important for policymakers, and standardization, clinical trials, and other research. But what we need, and I think what would be needed in places like Yemen, where there are poor resources, is really simple tools that can identify the patients very early on and not wait to see organ dysfunction. So the final chapter for the Phoenix score is not yet written, and there are a lot of investigations going on at the present time to look, and there are trigger tools that are available in high-income countries and certainly a few in low-income countries. So I'd like to thank you for your time, and I'd like to encourage everyone to join the Global Sepsis Alliance, for which I'm president. As there's an African proverb which says, if you want to go fast, go alone. If you want to go far, go together. And I hope you will join us. Thank you very much for your time.
Thank you. So I think it's time for break now. So we will have 2 breakout rooms during which, as I said earlier, we can possibly interact with each other. And we hope to be back to resume the sessions at 12 p.m. UK time and 2 p.m. Yemeni time. I'm just looking for the admin to allocate the breakout rooms. Okay, I hope everyone is back, and at least the breakout room I joined with Dr. Sally, we had quite a few conversations. I hope people in the other breakout room also had shared some views. All right, so we're back for the next topic, and it gives me immense pleasure to introduce Dr. Sally Sadasivam, who is an urgent care family physician in Gateshead, UK. She's also the medical director of CBC Health Federation, which is an organization that provides urgent primary care in Gateshead. Prior to this role, she was the director of undergraduate medical education for Durham and Darlington NHS Foundation Trust, where she supported and delivered medical student training. In previous roles, she has been involved in providing national training to pharmacists and was a clinical exam lead for Newcastle University. So I think her profile fits perfectly to deliver our next talk, which is titled Sepsis in Primary Care. Over to you, Dr. Sally.
Thank you so much. So I can just confirm that you can see and hear me okay?
Yes, I can. Thank you.
Great. So thank you so much. So yes, I'm Sally Sadasivam, an urgent care family physician in the UK. And what I want to go over today, and there will be some repetition, which I think can be helpful just to consolidate information, but we're just going to clarify the sepsis definition that I'm using today and have a think about what are the priorities for primary care. We're going to think about when to suspect sepsis in primary care and then look at some case studies, so some examples of patients that I've seen who have had sepsis. And then, of course, sometimes we can't get a patient to hospital. Patients won't go, or maybe they shouldn't go. And we're going to have a little think about what we can do in the community to actually help these patients recover from sepsis. So a couple of things just to note. Firstly, the case studies have been anonymised. And what I described today describes primary care in the UK. So some of these things you may be able to adopt, but some of things you might need to adapt to your own clinical setting. So just have a think about that as we go through what is right for my clinical setting and what would I need to change. As we go through the cases, I'll be highlighting when various parameters such as blood pressure is abnormal, just to clarify that there is no national or international consensus on normal values for these parameters. So just bear that in mind. So this is the sepsis definition that I'm using, and we've heard this in previous talks, the life-threatening organ dysfunction caused by a dysregulated host response to infection. If I said that's one of my patients, that wouldn't make a lot of sense. So the way I would describe this to a patient is that you have an infection, it's affecting your whole system and making you feel very unwell. So that's our sepsis definition for this talk. So what are the priorities for primary care? The big thing is recognition. So we've already reflected that it can be hard to pick up. It doesn't have clear symptoms always, but it's really important that we do recognise it and don't miss it. Our next priority is assessment, and that should be rapid. So we don't want to delay definitive treatment. We need to think about handing over to our secondary care colleagues in hospital to ensure that patients are treated quickly. We've talked about the golden hour. And obviously that prompt transfer to secondary care where possible. I want to highlight that a lot of my resources have come from the UK Sepsis Trust. We have checked and it does seem to be accessible outside of the UK. So you may like to have a little look at this website, and it's got lots of really useful resources, including tools that can be used within primary care. This may be familiar, so we won't go through this again. But again, these are the key symptoms that we're looking for when adults present with sepsis. Again, we've also highlighted this before as well. So very similar to adults, again, the fast breathing, the sort of change in skin colour and mottled appearance. Rather than the extreme shaking, this time we're thinking about fits or convulsions. The rashes that don't fade when you press on them, it's a more common problem with children. Being lethargic, not waking up well, and feeling very cold. So those are the child sepsis flags. And today I'm going to be looking mostly at some case studies involving adults. And again, just to clarify, those under 5 may also have feeding difficulties, repeated vomiting, and not passing urine for 12 hours. So recognizing sepsis. So reflecting on my practice, I think there are 5 ways that I might recognize sepsis as a primary care physician. And one thing that is really valid, and I always emphasize this with my medical students and trainees, is your first impression of the patient. Just have a look at them. Do they look well? Do they look unwell? Or do they look really well and are you really scared? And that first impression is really valid. The next way to recognise is obviously the history. We have features within the examination, particularly the vital signs. And what has been shown to be valid is a clinician's gut feeling as well. So even if the history sounds okay, examination sounds okay, if you've got a gut feeling something's not right, then you should respect that and seek further assessment and help. And the final thing that helps us recognise sepsis is when a patient or perhaps a parent of a child feels really concerned, something's really not right with this person. Again, take that very seriously. So let's look at our first patient, and this is somebody with symptoms and signs of sepsis. So we'll call her Norma. She was a 52-year-old lady with a sore throat. And my first impression of her was, she doesn't look very well. She reported being unwell for about 2 days and felt absolutely awful, really the worst she's ever felt. Her sore throat was getting worse, she was feverish, she was still eating and drinking, and there was no significant past medical history. So moving on to her observations, her respiratory observations were fine, but as soon as I started measuring heart rate and blood pressure, those were abnormal. And this is probably the lowest blood pressure I've ever seen in my clinical practice. In terms of her throat, it was red, but there was no signs of tonsillitis or quinsy. So what I'm going to do is just talk you through how we might assess this using the sepsis screening tool. This is for general practice, which means it's for primary care. So let's talk it through with this case. So the tool says that we should start the chart if the patient looks unwell or has abnormal physiology. And this is a situation where we have both. So she looked unwell, and also she had a very low blood pressure and a fast heart rate as well. So let's start doing the assessment. Dr. Rahman from earlier mentioned particular patient groups who are particularly at risk of sepsis. This chart is for adults only, so we can see that for adults, an age over 75, having impairment of an immune system for various reasons, having bits and pieces going in and out of the body, like lines, catheters, broken skin, and people who use IV drugs, and then any recent trauma, surgery, or other invasive procedure. Those people are at higher risk. There are different charts for different groups. So there is a pregnancy and postnatal chart. So again, pregnant patients and postnatal patients are at risk, as are the very young as well. So let's move on to step 2. Could this be due to an infection? So I would say yes. She has a temperature, she's got a sore throat. I think that she's got a throat infection. So it doesn't meet any of these boxes other than other. So question 3 is, are there any red flags present? So she did not have an altered mental state. Her mental state was normal and her respiratory rate was normal, and there was no need for any oxygen. Her oxygen saturations were fine. However, you can see here, she had a low systolic blood pressure below 90. Her heart rate was on that borderline of 130. So she meets the red flag sepsis criteria. So we were asked to start the GP bundle. And when we say bundle, it's basically a list of steps to take. So let's have a look and see what the GP bundle says we should do. So the GP bundle says that within the UK, I should dial 999 and get a blue light ambulance. So 999 is a number that we would call to arrange an urgent ambulance transfer. I work within an urban area and very near a large city, and I would be very confident that I could get patients to a hospital within an hour. So there would be no need for me to give IV antibiotics in the community. If I worked in a very rural setting, and perhaps some of you are not within an hour of a hospital, then you could give IV antibiotics before transfer. And then we've also advised to alert the ambulance about a possible red flag sepsis so that everyone's ready to start treatment as soon as possible. Now, you might ask me, well, what would you do if her observations are fine? She said that she feels really terrible, worst ever. It was giving me that same kind of feeling of I might die type feeling. Well, what this guideline says, and you'll see I've highlighted it in purple and just made it a bit bigger for you, that if any of those sepsis symptoms are present, I should also call 999. So also arrange an ambulance and rapid transfer to a hospital. So definitely somebody who needs to be seen in the hospital. So my learning point for this is a structured assessment can be really helpful. And this particular assessment, you wouldn't need to be a doctor to run through it. And actually, your other healthcare colleagues potentially could use a tool like this to assess patients. Our next patient is somebody with signs of sepsis. So this was Elaine, who is a 42-year-old female with a chesty cough. And my first impression was she looks quite well. And I remember it was quite a challenging day, lots of really poorly patients. And I thought, excellent, somebody who looks quite well and can hopefully go home. She had 4 days of cough, it'd been getting worse. She had some green sputum, but kind of felt okay in herself with no fever. And we see cases like this all the time in the UK, and they're usually fine to be managed at home. But let's move on to the examination findings. She had a respiratory rate which was slightly elevated at 22, but a very fast heart rate of 160, and a blood pressure which was low at 88/46. So this is a patient who had a normal history, looked well, but when we went to the observations, we suddenly realised, oh, this could be sepsis. And again, going back to our chart, this would then trigger the urgent ambulance or urgent transfer to a hospital for further treatment. So one of the areas that we look at within the UK is a handover, because the problem is if we don't hand over what we thought ourselves, then maybe what we thought will be missed by the hospital. So we use this sort of model called SBAR, which stands for Situation, Background, Assessment and Recommendation. So I've just briefly put in some notes of how I might hand over this patient, and I may hand this over to the ambulance crew, or I might call the hospital if the patient was making their own way over. And it just pulls all the succinct information that can be transferred with the patient to make sure they get that important care. Particularly the recommendation that this patient has red flag sepsis. The key learning point from this, I think, is observations are really important. So if this patient gave the history, looked well, I may have listened to the chest and thought that she was okay for home treatment. It's really important to do observations on anybody who has an infection. So that's your oxygen levels, respiratory rate, blood pressure, and heart rate. And then you might like to use SBAR within your own settings to provide a structured handover. So this time we've got a patient with an infection but no sepsis. This was Jackie, a 52-year-old female. She had abdominal pain and blood in her stool. And my first impression of her was that she looks well. She's had 3 days of symptoms, and she's known to have diverticular disease, and she's previously had diverticulitis, and to be honest, this feels pretty similar. She had a mild fever, She was still eating and drinking quite well in herself. She has type 2 diabetes, which is controlled by diet. And on examination, her observations were satisfactory, and she was slightly tender on her abdomen, but there was no guarding. So that was all reassuring. So this patient does not meet the criteria for sepsis. But what I wanted to flag to you in this situation is the importance of safety netting. So there's a risk that she could go home and become more poorly. Perhaps the antibiotic that I was going to prescribe for her might not work, and she could become more unwell. And patients, if they've been seen by a doctor and reassured, then there's a risk that they might just hold on even if they're feeling more poorly. So really, when we see patients with infection, we should always be safety netting and providing advice on looking for these particular conditions. So if you're feeling more confused, if you're feeling breathless, if your skin's changing colour, your hands and feet are cold, if you're not peeing well, if you're rapidly getting worse, that would be the time to go present yourself straight to the hospital or whatever follow-up arrangement you might have within your own clinical setting. So learning point for this is that safety netting will help a patient recognise if they start to develop sepsis after they've been seen by yourselves. So here's our final patient. This is a patient with obvious sepsis, but this patient's not appropriate for hospital care. And this patient's not a real patient, but I've kind of taken some points from other patients that I've seen and built a patient to illustrate the example. So we've got Isaac, who's an 84-year-old gentleman who's got some urinary symptoms. And first impression is he looks really, really unwell. The background to him is he has dementia, so he has very poor memory and is not able to make any decisions about his care. He lives in a nursing home. He's been feverish, he's drowsy, he's confused, and actually he's already had 2 courses of antibiotics, but they don't seem to have worked. And now he's developed some flank pain as well. And his observations are very disturbed with abnormal respiratory rate, oxygen levels, blood pressure, heart rate, and a high temperature. And he's quite tender on his left flank as well. So great, if we follow our criteria, this patient would just trigger a 999 call, get an ambulance, send it to hospital. But sometimes that's not the right option for patients, or it might not be feasible. So for this patient, he had previously expressed a wish that he didn't want to go to hospital if he had infections like this. And his family really felt that he would get distressed going to hospital and it wouldn't be in his best interests. So let's have a little think about what else that we can do for him at home. So the first thing is to get some help. So we, within Gateshead, have a rapid response team, which is a nurse-led team who are able to come and support us if we have patients who need to be treated at home. So getting some nursing support is really valuable. So what can we provide at home? Well, let's have a look at the sepsis 6. And I don't think we've talked about the sepsis 6 so far today. There's different versions of it, but this is my favorite because it's easy for me as a primary care physician, thinking about three things that have to go in and 3 things that have to come out. So the things that need to go in are potentially oxygen, fluids and antibiotics. And 3 things that we should take out is a measurement of urine output, a blood culture and a lactate level. So this is the ideal situation. So in terms of oxygen, I might struggle to get hold of oxygen in the community, but I certainly, if the saturations are less than 92%, then I would definitely try and get hold of that. The particular patient I've described might be confused and may not manage with the oxygen. So again, if you don't have oxygen, just push on to the next step. But if you have it, great. The next thing is fluids. So our ideal fluid situation would be to give 500 milliliters of fluids intravenously. But again, we may not have access to this in the community. And even if we did, our patient may not tolerate that and might be trying to pull a cannula out. So when we think about 500 mils of fluids, of course, a standard bottle of Coke would be about 500 mils. You could have 2 glasses of water. So again, IV fluids are best, but any fluid is good. So that your patient's probably thirsty. So we can always give a fluid bolus of some water or soft drink. We've talked a bit about antibiotic prescribing guidelines, and this is what I would use within primary care in the UK. And I would look up our guidelines every time I'm due to prescribe antibiotics for a patient. And again, it just helps us to target the infection and avoid antibiotic resistance as well. So antibiotics, ideally IV, but again, there's been a lot of studies that have shown that oral antibiotics can be very effective, even in quite severe infections. So if your patient's unable to attend hospital, unable to get IV antibiotics, oral antibiotics are definitely worth a go. So 3 out, we're told we should measure urine output. We could potentially, if someone's at home and able to, they could urinate into a jug and we could measure the urine output. But equally, we might just want to pop in a diary, is he peeing or not? How often, and roughly, is it small, medium or large amounts? I wouldn't have access to blood cultures in the community, but the next best thing would be to culture the urine. So we can arrange that, and we can arrange things like stool cultures, sputum cultures, or wound swabs in the community as well, and those are easier to access. So again, you may find that you're able to take some samples, which could be helpful to you if you've got access to a microbiology lab. And lactate, I would tend not to do this within the community. It will tell me how severe sepsis is, but it's probably not going to change my management within a community setting. So we'll probably leave that one. So my learning point for this section is that if the patient can't go to hospital, won't go to hospital, or shouldn't go to hospital for whatever reason, there are lots of things that we can do in the community to actually treat sepsis. So I'll just leave this slide on the screen and just sharing a couple of my top resources that I would use as a family physician within the UK, and happy to take any questions in the meantime.
Thank you, Sally. That was really thorough and quite systematic. I liked your approach. Do we have any questions? Let me check before I ask ours. So one of the participants has posted that in Yemen, about 75% of population lives in rural areas, which is usually far away from hospitals. So what will be your advice on dealing with infections and suspected sepsis?
Yeah, so I think the ideal situation for sepsis is to be treated in a hospital environment. So if there is a hospital available, that would be #1 choice. The other important thing with sepsis is to try and get antibiotics in within the hour. So if your transfer is going to take a long time, if you think it's between now and being on that hospital bed, getting the antibiotics into the system, if that's going to be more than an hour, then I think it's worthwhile giving a single dose of antibiotics in the community. Ideally IV, but again, if you're talking long transfer times, we could try oral as well. Within the UK, our secondary care colleagues are less happy with that because they like to do a blood culture first before antibiotics are in the system because it can mess up the results. But at the end of the day, those early antibiotics are really key for survival. So I would go for it.
All right. Thank you. So I had a few questions, if you don't mind.
Yeah, no problem.
Some patients always look unwell. So do you have any advice on how we know if we should use our gut instinct in these cases?
Yes, that's a tricky one, isn't it? So our initial sort of first impressions can be really helpful. But then we probably need to back it up with something a little bit more robust as well. I had a couple of slides in here that I took out just because of the timing, but I do remember a situation where I visited a patient who looked like they had influenza, mild fever, runny nose, just lying in bed, feeling quite rubbish, but that's normal. That's what influenza does to people. But there was just something about that case, the history, examination findings, everything was okay. I just wasn't happy and I can't put my finger on it. And I ended up sending her to hospital and she deteriorated quite rapidly with an acute leukemia. So it was nothing to do with sepsis, but it just sort of demonstrated that gut feeling is really important. But that looks well, looks unwell. It's just that initial sort of triage to say, right, I'm not too worried about this patient, or I am worried about this patient, but then you need to gather some more information. And that might be, a persisting gut feeling. It might be there are features in the history of things that don't sound right, like blackouts or something like that, or features in the examination, particularly your observations being abnormal. So yes, people will look unwell. They don't all need to go to hospital. So it's just about that additional assessment afterwards. That initial instinct just gives you a guide, I think.
Okay, thank you.
But I've known certain times I've called patients in from the waiting room and I've just thought I need a little bit more information, but I will be calling 999. I will be sending this person to hospital. They really don't look well. Or equally, a child runs in, starts playing with all my equipment, messing my room up. I need to confirm that they're okay, but first impression, yeah, they're fine.
Thank you. I think another question on the chat is, do you think GP doctors are well trained in recognizing sepsis?
So we're talking a little bit in the breakout rooms around sort of public awareness and sharing information. So I think that's definitely has improved over the past 5 or 10 years within the UK. So we have the UK Sepsis Trust, which is a charity which is very vocal in sort of sharing people's experiences of sepsis. And you see signs, up in hospitals, or just saying they have some adverts on milk bottles so that, everyone ordering milk will be able to see this sort of warning around, sepsis signs, learn more about it. But also some of the jobs that I've done, it's been insisted that I do a sepsis awareness training module. So I think the awareness is definitely increasing. I think what sits alongside that is this general ABCDE approach, which I've not talked about specifically, but some of our other speakers have done. So even if you're not quite in the sepsis mindset, we all know that blood pressure or systolic blood pressure less than 100, respiratory rate more than 20, that's not good. Send them to hospital, even if we don't know what's going on. So I think sepsis care in the UK is pretty good. Again, Dr. Khan, you're a UK physician as well, and I don't know, you could perhaps give some insights into that as well. But I think it's definitely improving.
Yes, I would agree. We even in secondary care, I work at a secondary care hospital, so we now see more and more people getting recognized with sepsis early on, especially with blood cultures. So when I started as a trainee, we used to have pretty low numbers of blood cultures, but with education and training, now everybody knows once they arrive in ED, they need to do a blood culture first if they are suspecting sepsis.
Yeah.
So I think it's a work in progress, I would say, both for UK and countries, low and middle income countries, where education and training, and I think that is what INTERYem is trying to focus on to benefit for the future benefit.
Yeah, and again, if you train your general public to be aware of sepsis as well, it's another sort of safety net, isn't it? So even if your clinician is maybe not quite up to date, patients will come and say, I've read about sepsis, could it be sepsis? We say, just ask, could it be sepsis? And our patients will do that and, challenge us as well. And we need to be able to, tell them that it's not, and this is why.
Okay, so another question probably which has already been answered, but I think it's mainly to reiterate or focus. So children have a high heart rate and low blood pressure compared to adults. So, so how would you advise clinicians or say other healthcare providers as well on looking out for sepsis in those situations?
Good question. So a couple of things. I think with children, the first thing I would say is have a much lower threshold for just getting further assessment. What children tend to do is that they will sort of tolerate a higher degree of infection and illness, and then they'll suddenly crash. Whereas adults tend to have more of a sort of downward progression of their illness. So I would have a lower threshold for getting further support with children. That's the first thing. In terms of observations, yes, the normal ranges are different. And I've got a kind of printout thing, which I sometimes have on my wall, which just goes through, age, whatever it is, 2 to 4, this is what a normal heart rate would be. This is what a normal, we don't normally measure blood pressure in kids, but, normal respiratory rate, etc. The other thing which I've started doing more recently that I've not done in the past is central capillary refill. And that is, I certainly always do it on children. And what you just do is press the center of the chest for 5 seconds, release, and see how long it takes for that blood to return. And anybody who's got a capillary refill of more than 2 seconds, that can be a bad sign as well. And that's really useful in children where they'll hold on to their blood pressure for a long time. So it's not a useful measure. Capillary refill is really helpful. So again, if you've got lack of training and resources, capillary refill is so easy to do. And again, you can do it on an uncooperative child usually as well.
Thank you. So what symptomatic relief, not curative, can be helpful in sepsis? So we talked about, yes, you did talk about doing the investigations, maybe prescribing oral antibiotics, but things outside of infection directly, any other symptomatic relief?
Yes, I suppose paracetamol is the big one, isn't it? We probably should have mentioned that. So yes, paracetamol for anyone with a fever, that will give good relief. I don't know whether you would use ibuprofen or similar, but we tend to avoid that just because it can damage the kidneys, and the sort of dehydration related to sepsis can also impact the kidneys. So it just doesn't really help the situation. So paracetamol for symptomatic relief. I think the oxygen and fluids, which is part of that sepsis 6, again, that can give some symptomatic relief as well. People feel much better after a bag of fluids, I think. In terms of the particular patient that I mentioned, so somebody who's elderly and confused and really not suitable for hospital, and we may occasionally use things like midazolam just to slightly sedate a patient, but that would be unusual. I probably wouldn't go much beyond the paracetamol and the standard treatment.
And one last question before we move on to the next session, if that's all right. So sepsis can lead to, say, cardiac ischemia, arrhythmias as well, or even like other organ damage. So is there anything that we think about or do about in primary care for this, or is it only transferred to hospital?
Yes, I personally am not well set up for that kind of emergency treatment. As a community physician, I need my colleagues to provide expertise. Again, if somebody has got chest pain, probably talking about doing an ECG to confirm whether it is cardiac or not. I don't have those resources. If you are far away from hospital, you might give some aspirin, but then that can impact the kidney function as well. So I suppose for me, get them to hospital and let the experts get involved would be my like key consideration. If you've got additional complications on top of sepsis, that prognosis is probably not very good.
Thank you. Yes, and participants agree that it was a very nice presentation from a primary care perspective. Thank you very much for your presentation.
Okay, thank you so much for inviting me, and good luck recognizing and managing sepsis.
Thank you. You're welcome to stay for the rest of the talk, and we will now move over to the next speaker.
Okay, thank you.
Thank you. So, moving over, our next talk is by Professor Ignacio Martin Lucius. Yet another warm welcome to him, but unfortunately he is also unable to dial in today, but has sent us a recording of his talk kindly. So a little bit about Professor Ignacio Martin. He's a full professor, consultant, and research director in intensive care medicine at St. James Hospital and Trinity College, Dublin, Ireland. He's the chair of the critical care group at the European Respiratory Society and chair of research at the European Society of Intensive Care Medicine. He's a steering committee member of the Surviving Sepsis campaign and current chair of the European Network for ICU-related respiratory infections. He has published over 600 manuscripts in high-impact journals, and his H index is 99. So a warm welcome to him, and we will now play the recorded talk. Again, a reminder that any questions raised on the chat would be hopefully answered in the YouTube recordings available after the session. So we are now looking forward to the talk on non-culture diagnostics in low and middle income countries.
My name is Ignacio Martin Loeches, and it's my pleasure to be here in order to give a lecture about sepsis, key insights, future direction, and immediate goals. This is part of the INTERYem program, that is the International Network for Training, Education, and Research in Yemen. I've been kindly asked to provide a lecture about this topic, that is an important topic in my opinion for clinicians. And I am a professor of intensive care medicine and sepsis in Trinity College in Dublin, and a consultant in St. James's Hospital, also in Dublin, Ireland. So for this lecture, I am going to try to follow the following index. So I'm going to try to spend approximately around 15 to 20 minutes talking about how do we treat sepsis, what is the new definition in sepsis. We know that there is a new definition called sepsis 2.0, but I think that probably is not totally perfect, so we need to incorporate some things on that. Also, which are the different pathways in sepsis, and also to incorporate what is the definition of refractory septic shock, because I think that this is probably one of the most difficult problems that we need to overcome when we are treating critical ill patients. So let's start with the first one, how we treat sepsis. And I think that this is a bit of a reflection of how we are treating sepsis in ICU. And I think that especially for those that they are not having a huge experience in critical care medicine, we have a dilemma from what we learn in the medical school, that is this very easy order of symptoms, working diagnosis, treatment, follow-up. This is the route that we all learned that when we were in the medical school. However, the problem is that unfortunately, when we are in this school of intensive care medicine, especially in the sepsis route, we need to consider that we have to detect when the patient is sick. We need to acknowledge the recognition of the problem. Then we need to start immediately the resuscitation. Sometimes we don't have a diagnosis, or at least a very clear and definitive diagnosis, but this is not going to delay the treatment. So for that reason, what we do is we are actually buying some time while we are stabilizing the patient and we are putting the treatment in place. So obviously, when we are looking at the difficulties, how we treat patients, I think that this slide to me represents the complexity of critical care. I think that we need to incorporate many different areas that they are going to be associated to the improvement or the deterioration in a patient, especially when we are talking about energy in patients with sepsis. For that reason, we had the opportunity to write this manuscript that is actually in thorax about the management of severe community-acquired pneumonia. And I wanted to highlight that we have like three pathways that we need to incorporate when we are looking at how patients are developing an infection and how our body is going to be responding to this infection. I think that for those that they have a good background in immunology, maybe it's not super interesting, but I think that for those that we are clinicians, I think that it's important to acknowledge that the first lines of defense is innate immunity. So here is when the pathogens are going to interact with the first line of the immune system. This is going to create mainly a cytokine first line of treatment is when we are going to have this development of inflammation, and is going to be this cytokine storm that we have heard in different diseases related to infectious diseases. And first, we are going to have the second phase of the story that is going to be the adaptive immunity. The adaptive immunity is when we are going to have mainly a T-cell response, is when we are going to have more the type of nosocomial infections that they are going to be associated to this delayed resolution of the infections. Those are ventilator-associated pneumonia, those are nosocomial infections related to catheters, and these are the most difficult to treat infections. And as you can see, there is a big interaction in between adaptive, even innate, and there is something new in the middle. That is what we call trained immunity. That I think that this is again something that we have discovered over the last years is more related about what we consider the metabolic activity in the cells, and here you can recognize some of the pathways that we learn in the university, and we are going to get into gene expression. We are going to incorporate tissue factor and overexpression of genes that they are going to say what we have that we call an exaggerated immune response. So we are moving to the sepsis definition, and this is the reason that I call this sepsis tree. So when we are looking at sepsis, I think that what has been the difference from one to the other over the last years is that we were moving from that we call SIRS, systemic inflammatory response, where we have many features that they are going to tell me that the patient is developing some sort of dysfunction in different organs, but it is obviously something that is not very adequately addressed. So this is the fever, this is tachycardia, tachypnea, elevated white cells. The problem is we knew that many of these features, they were not really very homogeneous, and at the same time we had patients like, for instance, me, if I have a flu, that I might have fever, tachycardia, and it doesn't mean that I am septic. So for that reason, we move from this type of inflammatory response to what we call organ failure. And this organ failure was mainly related to how a dysregulated immune response is going to be associated to organ dysfunction in the context of infection. The problem is, for that new definition, we were incorporating that we call organ dysfunction. So in order to detect sepsis, we had to incorporate the definition of organ dysfunction. And the problem is that there were different tools that they were incorporated in clinical practice. And I think that probably the one that we knew more or we discussed more was the Quick SOFA. The Quick SOFA was a summary of the organ failure assessment tools. In this case, we were using mainly three. We were using blood pressure, respiratory rate, and neurological status, mainly to detect these three major organ failures. That was the respiratory system, the cardiovascular system, and the neurology system, especially how the brain was working. The problem with that is that we found that these tools, especially Quick SOFA, was not very, very good compared to SEERS and other tools that they are more, I would say, for detection of deterioration, especially on the wards that we used as the NEWS or the MUSE, that they are mainly related to different organ failures, because these scores, especially the Quick SOFA, unfortunately was not a very good screening tool. So for that reason, as you can see in different guidelines, they disencourage the use of Quick SOFA against others that they were going to be less specific but much more sensitive. That is what we want when we have a patient with sepsis. At the same time, we have had different ways that we wanted to analyze the different definitions. This is a very interesting paper because one of the things is that how episodes are going to fulfill the criteria that we have in sepsis 2 or in sepsis 3. Sepsis 2, more inflammatory response. Sepsis 3, more about organ failure. And as we can see here, is that yes, we have some adequate correlation in, as we said, severity, but we have a major problem of how is the correlation with a proper or adequate episode of sepsis in this patient. So for that reason, what we can see is that probably the one that is incorporating sepsis 2 and 3, it was going to bring us the best, especially when we are trying to correlate this with positivity, in this case with blood cultures. It is not surprising that the majority of the scores, as I mentioned before, the Quick SOFA, has a correlation to scores that they are used in other infectious diseases. This is the case of some of the scores that we use in pneumonia. So they are, as you know, different one, PSI, CURB, SMARCOP. I put the example of CURB, 65, and it's not surprising that these scores, what they are going to do, is pretty much similar what the Quick SOFA did. So was going to try to analyze blood pressure, confusion, and in this case it was not analyzing also renal involvement but the respiratory rate. So as you can see, very, very similar, because at the end, as we can see, is that just for instance in pneumonia and many different infections are not local infections. They are not just an infection in the lung. They are going to develop a systemic disease. And at the same time, what we can consider is that there is a bit of a number game, because you can see that if we apply one or the other, in this case we have a patient with pneumonia, respiratory rate of 24, with a BP borderline around 95-65, with a little bit elevated renal parameters and normal mental status. If we are using Quick SOFA, this patient is going to have a very low mortality, is going to have only 1 point, that is going to be mainly the respiratory rate. However, if we are using the CURB 65, we are going to see that this patient is going to have different features, so that is going to be a mortality of over 28%. So probably the most important summary of this is that there is no good score. I think that there is a good score depending on which place you are when you are going to analyze the type of patient. So for that reason, just to put you the example, as I mentioned before, about a patient with community acquired pneumonia, clinical judgment, and in this case, using the different scores, in this case, SEERS, Quick SOFA, or CURB, in this case was not CURB 65, so just CRB, you can see that the SIRS was the best because it has a very good sensitivity, poor specificity, but is helping me to do an adequate first clinical decision assessment. Then when we are trying to see in which place we are going to place the patient is where PSI is going to prepare us to say if this patient is going to require and monitoring, invasive support, the type of second we call decision making. So for that reason, this is important. Unfortunately, as I mentioned before, Quick SOFA was not very good. Obviously, when we are looking at the ICU admission, I think that is also important to consider that we are going to have an important feature with the treatment. So the thing is that when we are looking at the different treatments, I think that delayed of intensive care admission is one of the most relevant points when we are looking at this particular feature. And this is the reason that when we are looking at the type of treatment in ICU, probably one important feature, obviously this is depending on resources. I understand that probably in Yemen resources are limited, but I think that it's really important to be close to the patient and to try to bring the patient to an area where we are going to have an adequate monitoring or at least an adequate supervision, because we are going to have that what we call these 3 levels of monitoring in ICU. Probably the first level is level 1, so patients that they are going to have a high risk of deterioration, that is probably only needed some monitoring, clinical assessment. The second is going to be those that they are going to have a single organ failure. So this is the typical one that they are going to have post-operative assessments or not very high intensive care, but level 3 are those that they are going to have multi-organ failure. And probably the way that we are treating the patients more and more, I think that is similar to this type of picture. So we are moving from how we were in the past, that we were using these very close wall. So as we know, the ICU for walls very, very far from the ward, and now we are breaking those walls. They are going to permeate the ICU care into the ward because we need to have a multidisciplinary assessment. So I think that probably there are some tools that they are interesting, like for instance the early warning scores, that they are going to help us, as I mentioned, NEWS and MUSE, that they are very extended and used in our system, and they are going to help us. So also I would like to highlight an important matter. So I think that in the last years we have had different discussions about how we are going to treat sepsis, and if sepsis was an overstatement. This is probably something that I don't agree. I think that we have seen that there is more and more elderly patients that they are in our healthcare systems. This is just the picture in Europe, that we can see that more and more we are going to have much elderly patients. And also in this paper that it was related before, that we call the sepsis hysteria. So Mervyn Singer and colleagues, they defined that the majority of the deaths were pretty much not easy to avoid with the problems related to elderly, and that means that they are almost 80% of the deaths in this particular area. However, I think that in these patients probably is where you are going to develop more resources because you are going to have better results. So we know that there are some patients, especially those that they are over 85 years of age, that you might say that using a resuscitation bundle is not going to change, but we demonstrate the opposite. We demonstrate that in those patients that they were very elderly, just to adequately resuscitate them could change dramatically the survival of these patients. So for that reason, I could say that yes, we need to accept that they are patients elderly, that they are patients that they are not going to have a lot of support. We need to be realistic, but also considering that in some patients, just a small intervention is going to mean a lot for those. I'm going to move also to some manifestations of how we look at the disease. This is a sub-study of one of the an important randomized control trial that was a trial that was done in the Netherlands in patients that they were with a bundle of treatment in the ambulance pre-hospital. So as we know, it's something that we don't have in Ireland and in many countries. But I think that when you analyze these patients, I think that that was super interesting. What we can see is that sometimes when we are going to adequately assess, like for instance, one important factor for trigger of detection of deterioration is going to be heart rate and temperature. So we know that if we have a patient with 120 beats per minute, or the patient is having 40 degrees of temperature, obviously these are patients that they are going to have risk of deterioration. However, I think that it was very nice to address that what they did in this study. I understand that they were using machine learning, so I'm not saying that you can use these in clinical practice, but it was quite interesting that when they put a threshold in 70 years, you can see that the H rate and the temperature is going to have a dichotomous effect. So, and you can see that how the temperature and the heart rate is going to be manifested difference in patients that they have a different age. And this is something that we see. Patients that they are more elderly, they are going to develop temperature in a different way and heart rate in terms of response different. So for that reason, as I mentioned before, I think that we need to incorporate different that we call sepsis pathways. This is the reason that if you look at this slide, is a bit a busy slide, but it's trying to integrate everything. I think that from what we call infection until death, we have like different steps coming from this still valid inflammatory response to hypercoagulability or permeability, then tissue damage with organ perfusion and failure, and then up to lack of vascular integrity. I think that this is the most important part that we are going to consider, and I think that that is going to be manifested by an increase in lactate levels. Probably this is important when we are assessing our patients. I understand that in some patients we are incorporating the severity when we are treating, but this is an important matter, an important factor where we discovered years ago that we can see that patients that they have cardiovascular instability when they have pneumonia, they do respond similar to those that they don't have cardiovascular instability. In other words, patients that they are not having any vascular issues, like for instance, not a need of a vasopressor, they are going to have a room for improvement when we are giving adequate antibiotics. So for that reason, I think that it is important to know how we are treating the patients and at what time we are treating the patients. So for that reason, I think that it is important to also give the value to some particular features. I think that we have had a lot about the use of lactate, and this is the reason that it came into the definitions. However, you can see that more than the single number, you can say that more than that, probably the lactate at 6 hours is going to have a very important factor. So clearance of lactate is going to be an important factor. And this way that we are going to see how things are moving are going to have an important value when we are treating the patients. Obviously, we need to understand that it's not only that we call blood pressure, is not only what we call lactate, but also there are some features that they are really difficult to incorporate. And in this case, this is a study that we published this year. It's a randomized control trial that we did in patients that they received albumin, and what we can see is that the microcirculation of the patient impacted dramatically with the use of different resuscitation tools, in this case with the use of albumin compared to the use of other fluids. And finally, and these are my last slides, I'm going to move into the definition of refractory shock. I think that we are going to start with refractory definition. So that means that is something stubborn, something resistant. And for that reason, we have had like different ways that we wanted to define refractory. That probably started in 2018, even before the consensus that was with the sepsis 2 definition, that in this case refractory was not addressed in this sepsis 2 definition. But I think that there are some particular clinical situations, like for instance, when the patient is, despite of hypotension, developing end organ dysfunction and a certain level of vasopressors, or when you need to go over a certain threshold. So we did a systematic review, and in this systematic review, what we found is that there are like many different ways in order to call that we call refractory. You can see on the on the right hand side of the table the different dosage of norepinephrine that different people are using, from low numbers, as you can see in some of the papers from Asia, from Japan, that you have a 0.3 micrograms per kilo per minute, to others that they are going to be quite high, like it happens, for instance, in France, in this paper from Marc Leon and colleagues. And finally, I think that this is more a conceptual issue. I think that we need tools when we are moving towards how we integrate the way that we are treating the patients. And I think that this is the reason of the emergence of the phenotypes, that they are going to provide us different characteristics in order to understand better how we are moving from dysregulated host response infection. And this is the reason that, as I mentioned, we are moving from phenotypes to what we call endotypes. So that means how the patient is going to respond against the infection, especially in some particular features. The thing is that we need, obviously, tools. And this is the reason that we are using, for instance, the way of artificial intelligence and machine learning. That is nothing but this a way that we are going to see when we have different pathways, that a machine is going to create a generative algorithm that is going to help us and is going to create, as I mentioned before, that we call endotypes. However, and I'm going to finish with these last slides, that I think that is important, that when we are looking at where we are now, you can see that we have improved the way how we are looking at the patients with the use of more biomarkers, more molecular treatments, more remote monitoring. But I think that it is probably how we interpret the data. I think that is probably going to be cheaper for some particular healthcare settings, rather than to have very expensive devices. So probably adequate way of how we are going to analyze the data. So this is the reason that probably what we need is we need to have an homogeneous way how we treat and how we talk about the patients, because in many cases we have problems of how we define, in this case, refractory. So because we need to see that we need a common language, and probably less related to research and more in the clinical practice, how we are going to get into an adequate reversibility in patients, and we are going to see how we can expedite early recognition and especially treatment, because we know that this delayed recognition and therapy that is going to be associated to mortality. So thank you very much for your attention, and I hope that you can enjoy the rest of the meetings and the speakers. Unfortunately, I'm not able to give the lecture live on, but it could have been my pleasure to have the opportunity to meet you in another occasion. Thank you very much.
Thank you. So we are now breaking up for lunch break. So it's for and half an hour. We hope to resume back at 1:30 p.m. for UK time, and resume back at 3:30 p.m. for Yemen time. And gentle reminder that the breakout room is open during the break as well, should people wish to discuss. Hope you enjoyed the morning sessions, and looking forward to the afternoon session on infection practices, infections in Yemen in practice. Thank you.
Okay, Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back for our second session. Just before we proceed, I just want to check you can all hear me. Yes, okay. Thank you very much, Dr. Norman, for coming to me on the chat. Okay, so I hope you all enjoyed the morning session, which was focused mainly on sepsis. It's a very, very important topic. We know this is one of the #1 killers in our societies after trauma, and there is great opportunities for high impact in terms of recognition and early treatment, especially antibiotics and the golden hour concept. And many thanks for all our guest speakers for dedicating the time for the session. We are going to start our second session for the day, which will be focused on the infection intensive practices. So we will have 3 talks followed by a panel discussion. The panel discussion will include everything that we discussed today so far, as well as brainstorming ideas of how can we actually use the knowledge we have gained today and the updates we have heard about, and making it translate it into actually something useful for the patient in Yemen. So what we will do, just kind of an overview. So we have 3 talks followed by a panel discussion. The talks we have is sterilization and infection control for reusable medical equipment in Yemen by Dr. Zaid Al-Jamil. And then we have evaluation of malaria surveillance in Yemen using updated CDC guidance by Dr. Labiba An'am. And then we have the last talk on evaluation risk and factors associated with drug resistance TB in Yemen. We hope Dr. Ali Saleh Jabr will be able to join us. He sent in his apologies. He may be not able to make it, but we will see. So I will start. I think Dr. Labiba Anam wanted to start first. So let me introduce Dr. Labiba so that we all know who is our guest speaker. So she's been working as a polio and measles surveillance officer at the government level in Yemen. She's also been a director for cholera control program and deputy director for electronic integrated diseases early warning system, and assisted in the YFETB in obtaining quality improvement assistant award presented by the TFINE. Currently, she is working as a resident and supervisor and deputy director with the MOPH. She's an author of a number of research articles on surveillance, analysis, and evaluation. So she would be the best person to talk to us about today's topic. I would like to welcome her. If you can unmute yourself, thank you very much for coming today. I wouldn't want to take any more of your time. You can start with your talk. Thank you.
Good afternoon, everyone. Thank you for joining this session. My name is Labiba An'am, Deputy of Yemen FETB Director at the Ministry of Health and Environment. I'm excited to be here today to share insight on evaluation of the 2 malaria surveillance system in Yemen. Let me share my presentation. Can you see my presentation?
Yes, we can see your presentation. If you go to presenter mode, then the screen will be bigger.
Yes.
That's perfect. Thank you very much. Yeah, we can see it now.
Okay, let's start with the global malaria scenario. Malaria is one of the most severe public health problem worldwide. It's a leading cause of death and disease in many developing countries where young children and pregnant women, the groups most affected. According to WHO World Malaria Report, in 2023, 263 million and 597,000 malaria deaths occurred worldwide. Half of the world population at risk of malaria transmission in 85 countries and territories, and 95% of the death occurred in the WHO African region. In Eastern Mediterranean region, between 2022 and 2023, there were an increase of 62% due to a large increase of 3.7 million malaria cases in Pakistan from malaria outbreak caused by catastrophic flooding, which initially affected 30 million people. And also there is a significant increase in Afghanistan from 188,000 in 2022 to 424,000 in 2023. Also due to instabilities and serious security issues in the Sudan, incompleteness of reporting in Yemen and concern about data quality in Somalia, it has been difficult to obtain sufficient reliable data to estimate the recent trend of the burden of malaria in these countries. For Yemen, Yemen is a high malaria endemic zone where 68% of population live at risk of malaria. Regarding the objectives of this evaluation, there were to determine the level of usefulness and of the malaria, the assess and compare the performance of the two systems, their attributes such as simplicity, flexibility, representativeness, data quality. Finally, to provide for improve both systems. Methodology, 6 steps of CDC updated guidelines for evaluating surveillance were used in Sana'a City, Yemen. Sample where the 31 at the governorate, district, and health facilities levels. For data collection, disk review and pertinent literatures, in-depth interviews with central stakeholders, and semi-structured questionnaire were used at district and health facility.
We just lost the slides and the presenter. Dr. Labiba, are you still with us? I think that must have been because of a connection problem. So we'll give it a bit of time to reconnect. Okay, apologies everyone. It looks like Dr. Labiba has lost connection because she's completely disconnected from the virtual meeting in the middle of her presentation. We just hope that you will be able to reconnect. While we have this time, I would like to take this opportunity to put in some topics for discussion later on by the people who are present. One of the breakout sessions, there was a really good, interesting discussion about how can we raise awareness, not just amongst doctors, but also amongst patients about sepsis. Find a very simple and concise, easy to communicate and understand the message that we can transfer to everyone. So I'm happy to leave this as an open. So if anybody wants to talk and contribute, you can please put your hand up and we'll. Oh, Dr. Libby, are you back with us?
Yes, I am back with you. Sorry for this interruption. Okay. It's due to internet connection. It's very bad in Yemen, as you know. I will.
Yes.
Reach. Okay.
Okay. Thank you very much, Dr. Libby, for joining us again. I will just put in some topics for discussion. So we will pause on my idea about discussing the topics, and we will do that afterwards. For now, we'll just carry on with Dr. Labiba's talk. Thank you very much. Please carry on.
Yes. Thank you. As we say, the data analysis was analyzed by EB-Info 7.2 version. Yes and no question used for measure the usefulness indicators, and the 5 Likert scale method were used for other attributes, such as simplicity and flexibility. We use the scoring system that include if the attribute has less than 14% as a mean poor, we will indicate to it by red color, and if it was from 40 and 60 to 60%, it will be has poor performance with the yellow color, and it would be average if the score was between 16 and 80%, and also indicated by the orange color. Good for good performance will be from 80 to 90% with light green, and greater 19% will be excellent with dark green. For the results, the first section relates to the findings from this review to describe the integrated malaria surveillance system. A national malaria control program launched in 2000. The malaria data come from 2 surveillance systems: the integrated malaria surveillance system and the electronic integrated disease early warning. Integrating objectives provide timely, reliable, complete data information, and guide the timely detections to malaria epidemics within the first 2 weeks of its occurrence. This is the data. This is the data flow of malaria program or an integrated malaria surveillance system. The data comes in hard copies to the district level, where at which malaria units are found. At malaria units, the data transferred to the soft copies and sent to the governorate level, where data revised and approved before sending to the headquarters at the central level. From the central level, the program headquarters sent feedback to the different levels of reporting at the governorate and district level and health facilities. For EDU's program, EDU's began for governorate in March 2013. There were 3 expansion phases. The first one was, as we said, in November, with the 215 health facilities are included. The second phase was in 2015, where 6 governorate with 435 health facilities are included, and 2020, where 22 governorate with the 2,378 health facilities were included. EDUs merged with integrated surveillance system in 2017 to become electronic in this early warning system. EDU's objectives were outbreaks at any early stage and take necessary response to prevent and limit occurrence. To show the data flow of EDUs, that data comes from health centers on Sunday to the district level, and sent from the district level on Monday to the governorate level, and also sent from the governorate level on Tuesday to the central level at the central level. And the feedback comes from the central level to the different also report or notification levels on a weekly basis. Section 2, finding from in-depth interviews. This table shows the integrated malaria surveillance system and EDU's usefulness indicators. We want to say based on CDC guidelines, the usefulness met one of its or and planned uses. So from this table, we can see that integrated malaria surveillance system can meet 2 of its uses fulfilled, which are monitor trend of malaria spread and identify study areas for survey. For EDU's program, also it
I think you probably know whenever I come back on the screen, it means that we lost the disconnection again. And I know we are working with very limited internet connection in Yemen. So thank you again for August the speakers for trying their best to join us and tell us about the current situation from the ground, even though they know they may be interrupted multiple times. And thank you for all our attendees for their patience and persevering with this session. We're going to give Dr. Labiba a couple of minutes because I'm sure she will rejoin like she did earlier. It seems to be that we've had more speakers from Yemen who almost lose the internet connection at the same time. So it might be something they all experience at the same time. Just to remind everyone, after the conference had concluded its purpose today, we will be sending you feedback link. The feedback link is very important because that's how we learn how to make these conferences even better. We also want to know what we did well so that we can do more of that. Upon receiving the feedback, we will send you a certificate of attendance. Okay, excellent. So Dr. Zaid Al-Jamil is back, so excellent. So Dr. Labiba is still trying to connect.
Can you hear me?
Yes, we can. Yes, please carry on where you left off. Thank you very much.
I am sorry for this interruption.
That's okay. We understand that the connection may not be the best where you are. And we understand not just you, other colleagues from Yemen also had experienced the connection dropping.
Yes.
So we appreciate that you're trying your best, and we appreciate your patience and the patience of our people who are listening and attending as well. Feel free to carry on. Thank you.
Thank you for you also. Okay, as we said, the findings from structure questionnaire revealed that our participant characteristics were 58% were nurses and 29% were lab technicians, 30%, 13% were general practitioners, and half were females. For table 2 shows the qualitative attribute of the 2 systems. Based on the scoring, the sum overall mean score of simplicity was 48% for EDUs. That indicates a poor level of simplicity for integrated malaria surveillance system and good level of simplicity for EDUs. The overall mean flexibility score was 71. That's mean the performance was average, and for integrated malaria surveillance system, and 100%, and this means excellent performance for EDUs. The mean acceptability score of integrated malaria surveillance system was 34%, where this indicates poor performance compared to 97%, which is excellent for EDUs. The overall stability of integrated malaria surveillance system was poor, 46%, while it was average for EDUs, 67%. Table 3 shows the quantitative attributes of the both system, which are representativeness and data quality. By reviewing the integrated malaria surveillance document that revealed 75% of the public health facilities and only 29. However, EDU's program covered 97% of the public health facilities and 46% of the private facilities. For timeliness, as we know, timeliness reflects the speed between steps in public health surveillance system. For EDU's, timeliness and completeness by default are 100%. That indicate excellent performance level. we could not calculate the timeliness and completeness for the integrated malaria surveillance system, as the reporting system had collapsed since 2014. The overall scoring or mean score for all system attribute was 42% for integrated malaria surveillance system and 87% for EDUs. Surveillance system has poor performance and the EDUs has good performance. In conclusion, integrated malaria surveillance system with overall performance level poor. However, EDUs also met and found to be useful and met its objectives. And with overall performance good. Recommendation: integrated surveillance system and EDUs need to be integrated where both system advantages utilized, take in consideration both system objectives and capacities, needs. Therefore, should agreed on new variables to be collected. Stakeholders should learn from inter-surveillance system experience regarding sustainability rates, find innovative method to ensure sustainability. Thank you.
Great. Thank you very much. Thank you very much, Dr. Labiba, for your talk. And it's very, very interesting to see how you do the surveillance and what actually are the main results of the surveillance. And we have discussed many times before, in order to be able to do something impactful, we need to know exactly what's happening on the ground. And that comes from audits, comes from surveillance, and from a good data collection. I will just go to our next speaker and just check if they're already. Dr. Zaid Al Jamal, are you with us now? Welcome, Dr. Zaid Al Jamal. So just to a brief introduction about yourself. Thank you very much for coming to give us a talk today. And just to introduce you to everyone who's listening, Dr. Zaid Al Jamal, he's a supervisor of infection and prevention and control and epidemiology at the University Science and Technology Hospital from 2015 onwards. Prior to that, he was supervisor for residency therapy department, University of Science and Technology in Sana'a. And he is also a member of the Ministry of Health team for infection prevention and the Ministry of Health medical waste management and also epidemiological surveillance in Yemen. A very important part to play and kind of almost a start really to assess what's actually needed on the ground. So thank you very much, and please, I don't want to take any more of your time. Please carry on, share your presentation, and the floor is yours. Thank you. If you just unmute, or we can try and unmute you, admin team can unmute, please. So it appears that you have been unmuted from our end. So if you just check your microphone settings, make sure that you have a microphone that actually connected. It's still not working. What I would suggest, if you have a mobile phone, you can also join in via mobile phone and see if that works. So you can join in via laptop or tablet for the slides, and then mobile phone for the microphone. See if that works. Okay, Doctor, what you could do, you could write on the chat to our admin team. They will be able to help you if you type, because we can't hear you at all. We can see you perfectly, and I'm sure you can potentially share your slides, but we can't hear you. While we are sorting this, we can't hear you at all. Just try and type instead. We can't hear you. Okay, apologies everyone for this technical difficulty experienced by our guest speaker. It's on the case, so we will get him to log in from a different device, and hopefully that will solve the problem. In the meantime, we can go back to the discussion we had earlier, and I'm happy to open the floor for ideas, which is how can we raise awareness in the best of ways regarding sepsis, and that could be recognition, that could be data collection, that could be treatments, something simple and can save lives straight away. Anybody wants to start speaking about this? So I have asked the admin team to enable the
Dr. Wahib,
raise in hand
can you
function.
hear me?
Yes, we can hear you. If you please introduce yourself. And
I am Labiba.
Dr. Labiba,
I would like
okay.
to answer. Yes, I would like to clarify some abbreviation for Dr. Khaled. He asked me to clarify a few abbreviations that we are used in my presentation, such as the National Malaria Control Program, which is NMCP, stand for National Malaria Control Program. IMSS stand for Integrated Malaria Surveillance System. EWS stand for Electronic Integrated Disease Early Warning System. I hope it's clear.
Okay, great, thank you. Excellent. Any other questions? I can't see any other questions. However, the floor is open until we get our next speaker set up. The floor is open for anyone to, either raise questions, discuss cases, or talk about the idea of raising awareness that I put to the floor just now.
Dr. Wahib, if you allow me.
Of course, please, if you introduce yourself and
Yeah, my name is Khalid Sremi. I'm a professor and head of department working here in Qatar in University of Doha of Science and Technology. I'm from Yemen originally. I came from US and I did my PhD from UK. So they just, I think it's not the first time for me to be in the interim. I think 2 years ago we had this kind of meeting. And as we discussed before, I think the most important things is now what we're gonna take away messages from here.
We just lost your voice, Dr. Khalid Rami.
Yeah.
Okay, Dr. Khalid, are you back? Okay, while we are trying to get Dr. Khalid back, anyone else? Oh yeah, you're back with us.
Do you hear
Carry
me
on.
now? Yeah. It seems there is a lack of technology this today. That's what's going on in the technology. Anyway, just what I'm saying here, you need to be innovative in a way that Yemen situation is not that really suitable for traditional way of awareness. And I highly advocate if you can use social media as a way for awareness, because even with the bad situation in Yemen on all aspects, people are still using social media. So if you, after this meeting with INTERYem initiative, that we do a campaign about sepsis with at least 3 elements, which is if you create a logo, for example, sepsis in the middle, and 3 elements in the triangle, which is antibiotics, time, and infection. So we tell the people, sepsis is really an end result of these things. If you get infection, you might really end up with sepsis, which is really threatening. If you get sepsis, you need to get antibiotics, and you have to get it on time, which is golden 1 hour. So if you can, with this kind of awareness, create among patients, among community, simple language, then it will really help, because we know for fact there are many undocumented cases, either in the ICU or death due to sepsis in Yemen. No one know it, and that will help us at least an early recognition of the symptom of the sepsis, and we carry on. Okay, this is the 3 elements, and what are the common simple symptoms apart from the, for example, you have cold or you have malaria, etc. So if you can create a momentum of awareness, patients as long as health professionals, we create like synergy between provider of care and healthcare receivers. Because to be honest with you, we don't expect such huge intervention from health facility perspective or from policy and healthcare managers or those who are in charge of the health system, because the situation is very collapsed. So this is my take-home message from today. If you can really do some awareness, leverage in the social media, we think about it. Maybe you can activate it in a Facebook, Instagram, etc. Practical things. How we're gonna implement it, we can think about it. What we need only, we need the people who are
جرب
good
من
at
التليفون
digital marketing.
وشغل الكوتشي وشوف كيف يمكن أحسن يكون. يلا تمام.
Somebody jump in. That's
Yeah,
just
I think
the first idea to be reflected, and then let's hear from others as well if they have any other ideas as a take-home messages.
thank you very much. That's a really, really good insight, because I agree with you. Social media can be utilized to create a simple, high-impact intervention, which is making everybody aware of it. So then something quickly can be done about sepsis. And I agree with you. There will be so many people who die unnecessarily from sepsis that we will not be able to actually quantify and give a number because we don't have accurate data on the ground. And believe it or not, even in developed countries, still people die from sepsis. So it's going to be an ongoing battle for forever. The Dr. Abdul Wahid had some interesting comments he was mentioning on the chat. If Dr. Abdul Wahid can be unmuted and discuss with us what he was talking about in the chat, he was mentioning starting training doctors, healthcare workers on sepsis using some of the WHO online resources, which are freely available and very, very insightful. He also talked about collecting data and doing research. And this is something we are in INTERYem very keen on. We would be happy to work with people in Yemen. We will be happy to guide them through doing a project where they collect information. We help them with the analysis and we help them towards getting that published. So if anyone has interns or resident doctors or any allied health professionals that would like us to mentor them and how to get their data collected, analyzed, and published, we would be happy to provide that level of service. And this is really what we are all about. Is if we're able to conduct good the research, then we can definitely have a good influence on what happens next. And then the other thing is. Dr. Abdul Wahid talked about simple suggestions. Okay, is Dr. Abdul Wahid here? If you would like to have a chat, we'll give you the mic.
Okay, thank you very much, Dr. Rahib. Do you hear me?
Yes, we can. Thank you very much. We can online.
First of all, I would like to thank INTERYem for this opportunity and for giving us such a fruitful discussion and presentations from experts on sepsis. And this is great for Yemen and for all Yemeni physicians and peoples. As I mentioned in chat, I think the topic of sepsis is very important, and we need to consider it more seriously, especially in a conflict area and with all problems Yemen are suffering from. I suggest that in order to raise the awareness is just to organize a conference under the umbrella of one of the universities, Sana University, or under the Ministry of Public Health to raise awareness about the problem of sepsis, where some of the topics already presented can be represented again, and also new research or any abstracts and can be submitted to the conference and presented to raise awareness about the topics. And I think we have many of these abstracts are available, and many of our colleagues are conducting research on such topics. The other things is training. I think the important to launch a training campaign. I can call it on sepsis, and especially for health workers in primary health care, and how to track and to identify case early and refer it properly at the proper time. This is important, and we have, I think, WHO training materials, which was referred to this morning by our colleagues from Ghana. And the other things is to support, as I mentioned, research, studies, and publication in Yemen. Already we conduct. I will not say that there's no research in Yemen regarding these topics, and even in Yemen, FETB, we encourage research on such topics, and some of our residents are already conducting and presenting in conferences some of these materials. But still, we need to also to have more wider capacity to start doing such research on such important topics. Thank you very much, and I think our colleagues can add more and more. Thank you.
Thank you very much for your insight. Can you please tell us where you work and what position, so that we all know? Dr. Abdul Wahid.
I am working on Yemen FETB, Yemen Field Epidemiology training programs, and Ministry of Public Health on SANA, and I am presenting next week and on next Saturday on the conference about our experience in Yemen in Yemen Field Epidemiology training programs and its impacts. Thank you.
Amazing. Thank you very much for also agreeing to be a guest speaker. I'm glad you brought that, because I was going to remind everyone at the end of this day about next week's conference on public health. Thank you. Just kind of to illustrate the importance of what you suggested, here in the UK and also in the US, and I'm sure other countries do the same, they have something called Sepsis Awareness Month. And for a whole month, they conduct a massive social media awareness campaign, and talks, all kind of give online courses, and also be present on the ground. Sometimes they come to the hospital's reception, the entrance to hospitals, and they have a stand there. They dish leaflets and talk to people about sepsis, and they do that every year for 1 month. And these are developed countries with very good training and research capabilities and resources. Still they do this, and it's very interesting how countries where they need this the most, it's not done. So I think there is definitely great scope for introducing something like this, and we would be very happy to support anything and work with yourself and the rest of people here with regards to either doing it as part of a university conference or part of the public sort of Ministry for Health campaigns, because at the end of the day, we want the message to be reached, and we want the message to spread and save lives. On the US alone, I was just kind of somebody just sent me some data. 350,000 people lose life from sepsis in the US, and this is a developed country. So you can imagine how devastating this would be in areas where they have a collapse in health system. So we can definitely make an impact, and I welcome Dr. Abdul and others to join us in the discussion later on how can we actually network. And we're happy to create a group of like-minded people and start brainstorm ideas, and maybe start setting up something that we can call Sepsis Awareness Month for Yemen. We can be all part of this, and we can start it and make it a repeated thing every year for 1 month. We dish a really good, strong campaign, and we learn from every month we do this to make it better for the following month. I think that's probably one of the simplest things we can do, and at the same time, gain the most impact. Thank you very much. Does anyone else have wants to comment to come in on this? Dr. Zaid, are you back with us? Have you been able to sort out your microphone? So I can see Dr. Zaid, it seems that you've logged in from a different device now. And if we can unmute Dr. Zaid from admin team and see whether he is able to talk to us now. Okay, you have been unmuted. See if you can speak now. Dr. Zaid Al-Jamil, can you hear me? Can you hear me, Dr. Zaid?
Hello, assalamu alaikum.
Wa alaikum assalam wa rahmatullahi wa barakatuh.
You clear now?
Yes, we can hear you now.
Okay. I can start down, inshallah.
Yeah, you can share your slides. While we are preparing for this, just want to remind everyone to join us next week for the Public Health Conference. And again, it will be similar to this, worldwide experts and also local experts from Yemen talking to us about up-to-date ideas and interventions and how we can, and then we can discuss all together how we can actually put some of that into practice. Also, we want to form a network of like-minded people who want to do something that can be useful for the Yemeni patient. Dr. Zaid Al-Jamil, feel free to interrupt me when you're ready.
Yeah, I know. Corrected by not clear the PowerPoint slides for. Okay, now.
Let me see. I'm just sharing anything.
Okay,
So.
now.
Yeah, no, not yet. If you share your screen, say if you share your screen, are you on your phone or are you on a computer?
Not found the screen share. Not found for me.
Okay.
Okay.
If you are on screen share, then go back to your presentation. Click on the presentation, and then it should. If you can see it on your screen, then we should be able to see it on our screen as well. So now we can see the camera.
Yeah. Now.
One way we could do is if you were unable to share the slides, you could send us the slides in a file format. You can even paste it on the chat, and we can run it on your behalf from our end. You could just say next slide, and then we will click on next slides. And then, a last resort, you can present without the slides. We can just listen to you because most of the ideas you will be discussing will be interesting just by talking about them as well. I appreciate if you had statistics and graph to show us, we may not be able to see that, but I'm sure we will get the idea. While that's been sorted, coming back to the floor, anybody would like to add onto what we suggested about a month awareness, a sepsis awareness month for Yemen? If you have, please put your hand up or just post in the chat. We will unmute you and listen to your feedback.
Let me see. حتى الملف ليش علق؟
Does anyone have any questions for any of our speakers as well? If you have had a question that was not answered in the main chat, apologies, and this is an opportunity that you can put your hand up, and then we will you can post the chat. Or if you have had some questions answered, but you would like to follow up on the answer, please feel free to do so. Or if you have any other questions, or if you have any questions to INTERYem, please feel free to put your hand up and speak to us. Okay. So a good question from Dr. Abdulrahid. Does INTERYem have a representative or a focal point in Yemen? So we don't yet have a representative in Yemen as such as an office. But we have people that we have previously worked with in Aden, Sayoun, Taiz.
أنا موجود، ليش ما يطلعش عندي؟ يا أخي شالوا هذا الطبيعي.
Our resources. So we'd rather call it a collaboration. So we collaborate with people such as yourself and others. And you know, that collaborative effort is really the future. And this is what we experience also in the UK, that collaboration actually is the way forward. And collaboration, everyone who has something to add can add in their bit, and then someone else add in their bit. And then before you know it, it's a big, huge project and impact. We're still open for ideas, and I'm sure at some point we will have to have a representative as the work increase and the demand increase. We will probably reach that stage, but at the moment we're focusing on collaboration. I hope I answered your question. Dr. Mohammed Noman wants to say something. Okay, here I've just had a message from the speaker. I think we probably won't be able to continue with Dr. Zaid's Al-Jamil talk today, unfortunately. We were all excited and looking forward to that. No. Also, just on a follow-up, one of our objectives in INTERYem is within the next 5 years, we will have an office in Yemen as well, spending funding and putting a good case for it. So, Dr. Zaid, don't worry about the slides. You know, this is now an open discussion. Feel free to, you know, summarize your main points for the talk today. What would you like people to know about the current situation in Yemen, and based on your talk?
Hello?
Yes, we can hear you.
You hear me?
Yes.
Okay. Okay, I start now.
Yes, start now. We can't see slides, but you can just tell us about it. It's fine.
Okay. Infection prevention and control and sterilization of medical and medical reusable devices. Okay. We have now two category or two topics about the infection prevention in Yemen and USTH hospital, our hospital. You hear me now?
Yes, yes, hear you very well.
Okay, thank you. Okay, and we have experience about infection prevention in Yemen. Very nice in Yemen and in Sana'a. About infection control. About infection control. We have in Yemen that start introduction about infection, nosocomial infection, also called the hospital-acquired infection, are infection acquired during hospital care, which are not presented at admission, but occurring after more than 48 hours. We have hospital-acquired infection, hundreds of million of patients worldwide, and is the major global issue of patient safety. And 2 million health care associated infection occur in hospital every year. In hospital acquire also the developed and developing countries approximately 1.4 million patients acquire the hospital each day. And CDC in United States 1.7 million hospital acquired infection, 99,000 deaths each year. This estimated for globally for infection separated in UST in United States. The morbidity and mortality also the more in developing countries. Okay. Now IBC measures related to sepsis prevention. We have more points about this. Number one, hand hygiene. You know, 5 moments for hand hygiene. Hand hygiene very important to minimize the infection in health facilities. We have every year in UST in our hospital celebrated about hand hygiene every year, about decrease for decrease the infection or I'm sorry, nosocomial infection. And number two, aseptic technique. Invasive procedure, example catheter insertion and surgery. Safe injection practices, also avoid reuse needles and syringe. Antimicrobial, also microbial, very important for minimize the infection and sepsis in our hospital. Environmental hygiene. This is very important in our hospital and in Yemen. We have medical waste management administration in Ministry of Health administration, and we have also the in our hospital for segregation and the transport and collected and therapy. Number 6, surveillance and early detection for infection by we have surveillance and monitoring and follow up for infection in our country and in our hospital. Follow up and assessment every year, assessment for infection, but follow up every day for infection. Number 6, vaccination for pneumococcal and influenza and HB hepatitis B vaccine. All staff in our hospital take the vaccination for hepatitis B. Very important, the point, very important for vaccination for hepatitis B in our hospital. Education and training, that's very important in my strategy for my department and my officer and our hospital. Training and health education continue health education about training IBC protocols and standard protocol. We have now, as a chain of infection, agent and reservoir and border of exit and mean of transmission and border of entry and host. This is very important for training for all staff about this, and also training about how broken the chain of infection. All staff training about this. Very important, and my strategy for training our staff. Also, we have now standard precaution and additional precaution or transmission-based precaution. We have, standard precaution. Number one, the hand hygiene, very important. And number two, PPE, personal protective equipment, and how not recap or safe injection for training for staff. We have additional precaution for important. Now standard precaution, this maybe 7, very important. Number 7, reprocessing medical equipment, and talking about finish the introduction of an IBC. Now additional precaution, very important. We have 3 types or 3 category about additional precaution or transmission with precaution. Number 1, droplet precaution. Number 1, droplet precaution, and airborne precaution, and contact precaution. Now we have more steps about contact precaution. Number 1, hand hygiene, gown, gloves. Not all IBB, personal protective equipment, not. But the contact, we have hand hygiene, gown, gloves. Apply this only. Number 2, droplet hand hygiene and mask. Airborne, very important. Airborne, more in most of the hospitals in Yemen not have negative pressure room, and some facilities of health have N95 mask or respiratory mask. But number 2, very important, negative pressure room, very important, and with HEPA filter. But our hospital, in UST hospital, we have like this. We have negative pressure room and HEPA filter. Now, very important now with the contact, we have, the donning and doving. Donning both the PPE and prior to entry, and doving or remove the IBB. Also, the very important, what cases the airborne cases for precaution. We have 3 only cases or disease for airborne. Not all respiratory cases airborne. No, we have 3 only: measles, chickenpox, and TB. This only need for negative pressure room. Now, infection prevention control in Yemen. We have department and officer in Ministry of Health. Members also assessment every year, and training. We have committee We have committee for IBC in Yemen and our hospital, UST hospital, very important committee for manager of hospital and manager or director of medical. Also, we have head of all departments in committee IBC. Also, we have indicators and policies for IBC in Yemen and our hospital. Also, we have also the challenge very important, and challenge or lack of training in some hospitals, and weak compliance and limited resources and absence of monitoring and benchmark. We have now benchmark, benchmark, and applied to all SSI, PAP, and the bloodstream infection, and after that we have benchmark in hospital. This number one. Number two, we have also sterilization of reusable medical devices. Very important in here. Reusable medical devices are essential in healthcare, but require proper sterilization to ensure patient safety. Sterilization is critical process in infection prevention, ensure the reusable medical devices are safe for patient. Definition: sterilization, complete killing of all forms of microorganisms, including the bacteria spore. Disinfection, killing, or remove harmful vegetative microorganism. Antiseptic disinfectant that can safely use on living tissues. Okay, now we have common bacteria in our hospital or on all hospital, any places. How many times survival in surface? We MIRSA, with this very important in MIRSA and the training or staff, how trans the MIRSA to staff or the patient. Survival times of for 7 days to 7 months. Also, vancomycin resistant, very important, 5 days to 4 months. Acinetobacter of this is common in all hospitals, and challenge, maybe a challenge in all hospitals. Acinetobacter, if you do the culture. If you do culture, you know Acinetobacter. But if not do the culture, maybe not know the Acinetobacter. 3 days, all, not Acinetobacter only, but all microorganisms. 3 days to 5 months. Also, we have training about all this. Types of cleaning and disinfection and sterilization process, very important. We have cleaning manual and automatic cleaning. Manual maybe use the brush or clean manual, but automatic we have in some hospitals we ultrasonic machine and medical washer. In our hospital we have ultrasonic. Disinfection, low level and intermediate and high level. Also, we have sterilization, high temperature and low temperature chemical and gas. I'm talking now about all this. Device, we have now reusable device classification, 3 category, very important, all staff or in CSSD, very important, critical and semi-critical and non-critical. Any invasive to blood or tissue, very important, you know this. Critical, any machine or any devices to blood or tissue is critical, and need to sterilization and disinfection. And semi-critical, like the not invasive, non-invasive. This non-invasive or non-invasive, like the flexible and rigid flow fiber optic endoscopy. And non-critical intake patients okay, like blood pressure or mask or like the non-invasive, non-critical. Okay, now critical needs sterilization, semi-critical need disinfection, and sterilization. Non-critical need cleaning only. Now steps of sterilization process, you talking about this cleaning and disinfection and inspection and packing and sterilization and storing. Okay, automatically cleaning for very important for any hospital. Now we have some solution about disinfection. Now glyceraldehyde, Sidex, very important on all hospital now. In some hospital in our country use watery pouring the water. Hot the water. After that, put the instruments in water. After that, enough to sterilization instruments. But that wrong. Okay, we have sterilization, very important. In all hospital, we have for steam and ethylene oxide and hydrogen peroxide, plasma and dry hot. This is very important in all hospital. Steam sterilization, autoclave, ethylene oxide gas, also the important. But now not working in Yemen. The oxide because policies and like this. Hydrogen peroxide or plasma we have a machine like this, but challenge in sterilization sometimes not to have cassette for this. Okay. Sterilization indicators, very important mechanical indicators depended to for three category: time, temperature, or pressure. And chemical indicators, very important chemical color change when parameters met. Biological also indicators used for of spores and test efficacy. Okay, and instruments, sometimes we have, sometimes talking my staff about why sterilization llama, and how sterilization or disinfectant the mask, or, okay. Example, llama laryngeal mask airway, 4 times, need 4 times for use. After that, not uses. Okay, the CDC by CDC. And ampubage, how uses the ampubage in our department or our ward or in ICU like this? Only 30 times uses only, according to manufacturer. The CDC directive suggested the discarding disposable the N95 mask. Also, sometimes also many staff use the 100 times. 100 times. That's not wrong. This wrong. Need only 5 times. Only after that remove. Okay. Now, very important supporting classification system to use reference to determine the appropriate level disinfection and sterilization. Okay, the take-home points: cleaning, disinfection, and sterilization, the backbone of infection prevention and control. Prepare the cleaning is essential before any disinfection or sterilization process. If not cleaning or not disinfection, not sterilization. Also, steam sterilization is effective only when cleaning, cleaning, and also disinfection. What are the challenge in sterilization? In our country, in our hospital, we have challenge in sterilization. Number one, limited resource, not available the cassette, not available the instruments like this. and also an infrastructure very important. If now infrastructure in our department very important, in our hospital we have CSSD, and infrastructure very important, two-way, one way to dirty instruments and another way to cleaning instruments. Sometimes the challenge about institute staff training, or not have the staff fit. Errors, also the error in cleaning or packing, sometimes with the instruments after that finish cycle of sterilization, equipment malfunction, or maintenance issues. Sometimes not have manager or department for maintenance every day or every month for machines, our machines for sterilization or CSSD. Okay, conclusion, sterilization of reusable medical devices is very vital to patient safety. Prepare procedure and training and monitoring ensure effective sterilization, very important. Thank you. I'm sorry for interrupted my internet in our country. Do you have any question?
Dr. Zaid, thank you very much for your presentation. Thank you very much for persevere despite your internet connection. Even though we can't see slides, we got the message loud and clear. And thank you very much for all the hard work. And you touched on very, very basic elements of infection control that are essential. We're talking about sepsis and sepsis control, and how can we prevent sepsis, treat sepsis, recognize sepsis. But if we don't actually get the infection control measures, yeah, you mentioned first, we will be the ones who actually cause sepsis. So thank you very much for your talk. I'm just gonna check whether we have any questions on the on here. So we haven't got any questions on the chat. But from my side, I'd like to thank you for your time. If you were to do anything different to what you have done already with the limited resources in Yemen, I know we talked about hand hygiene and all that stuff. What would be the single most element that you think will have the highest impact, given the limited resources we have in Yemen at the moment?
Yeah, and have a resource in CSSD and central station supply. I have machine plasma, but not have cassette or indicator. Okay, like this. Not have original hand hygiene. Not have more hand hygiene for all beds in ICU, like this. And PPE. And PPE, personal protective equipment, sometimes not available in our hospital or on any hospital. Sometimes not available. Mask, not available. That gown. Very important this for minimize nosocomial infection.
That's interesting. And why are they not available? Is it because the supply chain, or because of the war, or because they are not looked as something important?
Because sometimes not entered to Yemen. To Yemen.
So it's because of supply.
Like this policy and yeah, like this.
Yeah. It's a very difficult situation to be, because I'm not sure how can we, as a small organization, influence that. What else can we do? Despite this, what can we do?
Okay, now in our hospital, UST hospital, private, okay, but in government, sometimes in hospital government, and now I talking about not in our hospital only, but all hospitals in Yemen, divided two types. We have private and we have general for government. In private hospital, sometimes available in private, but in another hospital not available. Okay, sometimes maybe use gloves many times. use mask many times. If now Zaid go to training to another hospital, need PPE doing and doing. Okay, not available in other hospital. Okay, apply to this difficult, but in private hospital available.
That's very interesting. So it seems to be that the private hospitals have the equipment and the, the infection control basic kit, but at the same time, the general hospital, the government hospitals do not have that. Is it because the private hospitals have priority, or they seem to be able to negotiate a better deal of whatever is left?
Sometimes like this, sometimes okay, sometimes.
Yeah. So okay, inshallah, what we could do then, this probably could be one of our maybe future projects. We can look into how to actually make these things available locally rather than importing. But yeah, thank you very much for your talk. Thank you very much everybody who stayed with us today. I think we will conclude the guest speaker talks, and now we'll open the floor for discussion about anything we have discussed today. And most importantly, I think we need to lay the foundation for the Sepsis Awareness Month and the ideas that we kind of already touched upon earlier, Dr. Abdul Wahid and Dr. Khalid, and any other ideas. So the idea is we want to use the knowledge we have gained today and the updates to see what we could do to help any patient who comes in with sepsis in Yemen.
Okay. Thank you for this conference. Very important in Yemen. Need like this conference and workshop. And thank you for Dr. Abdul Wahid, Professor Dr. Abdul Wahid Saruri, and thank you for all persons for this conference.
You're very welcome. You're welcome. I hope you stay with us, Dr. Jamil. If you stay with us, and we will see how can we all contribute. I mean, sometimes contribution could be just contacts. For example, in your hospital, you could say, okay, I can in my hospital be the person in contact for during the sepsis awareness month. You could potentially in your hospital you could pass on the digital material and things like that. If somebody is here who has a position in Ministry of Health, they can also get the Ministry of Health on board. We, from experience, the social media campaigns or like a health awareness month works well when everybody's involved, and that's universities, hospitals, and governments. So Professor Abdul Wahid had mentioned stuff that's really useful, and if he's still with us, please come on and you can further elaborate on your ideas.
Okay.
Thank you.
Inshallah.
Thank you, Dr. Rahib. Do you hear me?
Yes, we can hear you.
Okay, thank you very much. Again and again, we would like to thank INTERYem for this opportunity and for sharing the experience from south to north, and especially to Yemen in this critical moment and situation. I guess also want to add to the suggestions we mentioned before. If we can just to have simple newsletter, monthly, quarterly, about sepsis in Yemen, and updates, any figures, any research conducted, any new guidelines developed, and widely distribute this to hospitals and hospital staff. It will be good also to have it in Arabic and English. This may help to raise awareness and increase awareness about the problems. And one important thing is also to have a strong dialogue, I think we need with the policymakers to put sepsis higher in their agenda. And there is maybe a need for orientation sessions to the policymakers to show them the case and how it is important, and how the health system will be benefit from having good sepsis control, so they can help to impose any policy updates or any things. So these all things are highly needed in this critical moment in the Yemen, and we hope to continue with this efforts with all colleagues, and working on the same topics. And we in Yemen FETB very interested to guide our resident to conduct more research on this topic, and to have also a dialogue with INTERYem to how to continue this in the future. Thank you.
Thank you very much, Professor. Can I ask you if you proposed the idea of a newsletter, which is excellent, and I think that's probably a sustainable thing that can actually keep people interested, and maybe not just interested, but also known where to find latest information. If we had a newsletter system, how would that, do you think, how can you make sure that newsletter reaches the people who need to read this? Would it be like a list of emails? But we know some people don't check their emails regularly. Would it be Facebook? I don't know. There's so many different options. What would be the best way of getting it to the people of importance?
I think in Yemen, especially with the internet problems, WhatsApp becomes the more popular than, as you mentioned, the emails. And so we can send it. We can have even make a group on the people who participate in this event, and those who are interested to join this group, set control in Yemen group or anything, and we can send these newsletters to those interested via WhatsApp, because it's easier things than others, but still we can also try hard copies, especially for the libraries, for things, and we can try as much as we can different channels, and see what give the best outcome and best interest and best dialogue. Thank you.
Thank you very much. Thank you very much. That's definitely something that can be looked into from our end. Can I ask everybody who's here, if we were to launch this, do we have people here who have good links with the universities, who may be able to
Yes,
get the
Dr.
universities
Wahid.
involved? Of course, come
Dr.
in.
Wahid, if you allow me, first I'm thanking again for this opportunity today. Yes, I agree with the idea of the newsletter, when there are many communication channels so that we can, universities, I am belonging to the University of Aden as a professor of community medicine and public health, and have many students either in the master program. Also, we are in link with the Ministry of Public Health and Population through the residency program of the Yemeni Council of the higher specialization. So many things that we can. One thing that we can use is the health clusters and the WASH cluster. For the sepsis, I think it is good to have such information communicated with the existing clusters. I mean, they have mailing lists, they have WhatsApp groups. I noticed in the last period, everything we have communicated through the health cluster better than any other channel. So the health cluster, it is belong to the WHO or other organization. All organization working beside the ministries involved are inside such cluster. So this will be a good channel. At this end, also, I want to say that the relations with the Ministry of Public Health and Population is very important. We spoke before with Dr. Khalid and you before this, session about the strategic planning of the ministry regarding the infection prevention and control, regarding training, developing materials based on WHO modules. So they have a lot of work. And they have some experienced person from the WHO stay here in the ministry for around 2 years, making such, materials and training and so on. So there is some things in the ground that we can build on, that we can support, that we can work with. So I surprised that the people from the ministry today, none of them. I personally know many that are interested actually in infection prevention and control, in infection treatment, and this aspect all. And there was one conference actually regarding even conferences. We can, communicate with them like this. So, and they have now data that they can share about the training they have done, about the materials, about the things that have been done in around the last 2 years. This is that can share with you. Thank you.
That's great. Thank you very much. I think the health clusters are a really good idea, and making sure we align up with, the Ministry of Health is also very, because I think it adds a lot of power to the campaign, to any change, when we get these people involved, and it just gets the change becomes very, very meaningful. It's kind of a mass, magnifies the change. Well, thank you very much, and also I'm glad that you have such a wide reach within the university and the hospitals in Aden, and it will be an asset to have you as well, work with us in trying to propagate some of those projects and get people who have interests. Yeah, thank you very much. Yeah, exactly. Anybody else has any like they can, for example, provide their area where they can actually lead on their side, for example, any other contacts or ideas to add. For example, now we have the campaign, we have the newsletter, and we have the clusters as well for communication.
I would like to add. Yeah, I would like to add to what my colleague add is we should not forget the medical students, nursing students, those who are in health institutes. Those are the future leader of healthcare. So we need to create a momentum across the different level of the health sectors. And even though if you really to be proactive, we might create awareness not only about among healthcare providers. We need to go to the community, to the high school graduates, to the even the community leaders. This kind of clear momentum from the prevention point of view, and then because we don't want to end up look at this as a health issue within the health sector. As you know, healthcare is beyond health service, is beyond clinical thinking. We need to create awareness of everyone is responsible for infection, to prevent infection. Even the patient, when they are in the hospital, sometimes lack of awareness, they get infected. If they are aware, we have done a study a long time ago about empowering patients how to really ask your health provider to do the hand hygiene by themselves. And it was a quality improvement project. And because sometimes healthcare providers unintentionally they forgot to do the 5 moments in terms of the hand hygiene. But when the patient raises their voice saying, "Don't touch me. Have you washed your hands?" Because if you are a physician or nurse, you do a lot of things in the emergency. Sometimes you forgot to just do the simple things in hand hygiene. If the patient became like a source of the awareness, a source of barrier from prevention infection, all these, for me, it's important when you think about high impact interventions to ask yourself first, who is the stakeholders? Who are all people around these issues? From the healthcare providers, from the patients, from the public, from the community, and not to forget the policymaker as well. So we need really, if you can create a awareness that target everyone. We should not underestimate the role of media, traditional and modern media. So if we really want to create impact, we have to be smart, and we have to be comprehensive. Regardless of the tools, whether it's going to be newsletter, it's going to be something digital or something paper. This is, again, for me, is a product. But the question is, who are really the targets, and who are the easy, quick winner that we can win together, and how really we can empower people to be those who are caring about their health. Because people, in Yemen, there is a unique situation. People are in the social gathering. For example, it's those who are gathering in the what's called chewing gas. You might do some awareness in those places. Who should know, right? So we should leverage on all social gathering about our health issues. During wedding, why not to put posters from WHO, just print it and put it in the schools? I like your idea about month awareness of sepsis. It could be weekly, or it could be, it doesn't matter. The good thing is we start small but smarter. We need to move toward that. No one should really suffer from sepsis because of infection. Because if you're going to look only about the sepsis as an end outcome, and the infection is there, so it's like we are not closing the faucets. The water will be going on, dropping on, and then we just end with the iceberg. We need also to have a comprehensive way how really to prevent, how to control infection, and then how really we will deal with sepsis in a whole way spectrum of healthcare, from the community-based to primary care to hospital, even at home. So what's really important is the dialogue between us after this events, create a momentum group, and we can do a lot of things. It doesn't mean to have a big things at the beginning, could be gradually, and utilizing our colleagues who are inside Yemen, outside Yemen. And I will end up with utilize students. Students are really important to be part of this momentum. Students are important, and most importantly, multi-sectors. We should not forget nurses, technicians, physicians. All these, they have to be part of the momentum. Thanks again. I'm glad that we heard some colleagues from Yemen, Dr. Abdul Wahid and others. And thank you, Dr. Wahid, for your leading in this initiative. Hoping you can contribute to our beloved country by all means. Thank you.
Thank you very much, Khalid. We're really, really keen to be part of any service that could actually give the patient, the Yemeni patient, better, but also empower the Yemeni clinician, with good quality, up-to-date information, resources. And then as we progress at the moment in INTERYem, we have a mentorship program where we have a couple of doctors from Yemen that are being mentored by people in the UK. This is in a trial phase, and we want to scale that up in the future. So we cannot do what we're doing without your comments and feedback and involvement. We really, really appreciate all of you coming today, guest speakers and attendees. And actually, while we're talking, I've been taking some notes because there's so much that you all have added. That it's actually a really good project. I like the idea when you said, how to empower the patient. The patient can be empowered to actually feed into it. It's almost like there's a nice chain, and each link of the chain can reinforce the other. And if one breaks, it doesn't necessarily mean the whole chain is broken. It means the other chain can actually take the load. For example, with the hand hygiene, if, for example, the chain broke and then the doctor was too busy and didn't remember to wash their hands, but then the patient was the strongest link in that chain, that could pretty much restore the chain strength. And that comes from kind of, involving the patient. And I think it's really important as well. You mentioned about involving medical students. And I think involving medical students not only has a short-term gain, which is when they are involved, but also as these students become junior doctors and senior doctors, and then, move on to have their own practice, they will carry these fundamentals with them and use them and implement them, because it's not just something they read in a book. They actually contributed to when they were students. So yeah, thank you very much for the suggestion. And I 100% agree with you. I would be very, very privileged if people interested in today's talks and the attendees, if you're happy, we can add you into a WhatsApp group, and then we can update you on what's going on, and then seek your advice on issues that you will be better off advising us on how to go about it, and then linking up with the right right kind of sectors for pushing this forward. And like I said, we can start small and build up. As we build up, we will definitely gain more momentum and be able to integrate things that may not be able to do from the moment go. Thank you very much for your time. Anybody else would like to come on and add to this discussion, please? Great, thank you. And if we were to involve the Ministry of Health, do we have anybody here who may be able to facilitate that from their end?
For me, in Aden, I can communicate with them. I give you also communication, details. Dr. Amin. Okay.
That's great. Thank you very much. If we were to do something like that, is it something, do you think, INTERYem is, we do not get involved with politics at all, and we think it's very important that we remain impartial so that we can actually serve the patients and the healthcare professionals. So if we were to run a campaign like this, do you think we could do it as a whole thing in Yemen, or do we need to do the same thing but at different times? Or is that a difficult question?
I would suggest, as you said, INTERYem is not a political driven entity. You should be open for everyone. Here we talk about patients. Patients are human, right? Those who have a different perspective politically, they should not really stop us from doing what's as a human basic rights. So we can approach anyone showing this is the science, this is the issue, this is the problems. We are not representing any party, but we are here to help Yemeni people regardless. So, and then if there is anyone can pick it up from any part of the country, that's it. And I would suggest we should be more close to the academia, more close to the associations who really not involved in politics. So a non-government organization is going to be a one choice to look at this, who are working independently. Universities are, at the end of the day, they are delivering science. It's nothing to do with politics. I know politics somewhere is here and there, but for us as a professionals, as a researchers, as advocates, we don't differentiate, to be honest with you. And we should raise our voice clearly and to maximum. We will not really be biased. We are not really biased. We are really here to care about people. We are outside, and those people on side, if they cannot see something, we can see something, because we are a bit neutral. We are not part of any disputes. So I think sometimes we think the situation is bad. It's there is a barrier, but when you touch on it, you find people are very collaborative, very welcoming. So let's assume positively that if you put our intention to help people, I am sure at the end of the day, people will look at this positively, and we should have a positive perspective without any assumption or preoccupied thoughts. So my recommendation is our message to in this topic or other topics or any future issues to be natural, to be open, to be welcoming, and we are more than happy to send our help to any part of the country. At the end of the day, we are Yemenis, we are help for Yemen, and this problem of today, inshallah, one day will not be there. So this is my perspective of this. Yeah.
Absolutely. Thank you very much. We are definitely, keen on being neutral, because the patient is a patient. It doesn't matter where they are. The patient needs, the patient requirements is exactly the same, and the tragedy and the suffering is the same. And we are very sensitive to anything that may appear to be, affiliated with any political, because we know that means we will be, we will lose out on helping someone somewhere else. So our doors are open, and we are definitely, keen to maintain that. Thank you very much for reminding me about this. Okay. Honestly, we've got so many things that we can definitely start brainstorming and kind of designing a package that we can start rolling out. And I'll ask the admin team to get a group together. We'll add you to a group, and then we will discuss in the group a few things, and then take it from there. And I know some people here will be attending the public health conference we had. So it's, in a way, the sepsis control is infectious diseases, but also it crosses the public health domain as well, because we are trying to help not just one person, but it's the whole kind of, community and society with this kind of type of project.
If you allow me, Dr. Wahib, one point I would to add. We would leverage on the capability of our faculty there. For example, Dr. Abdul Wahab al-Siruri is really leading field epidemiology, which is most of them are residents and students who are interested in epidemiology. Maybe this is a entry points to start somewhere, right? So we should not ask to do something beyond our abilities. So I think Professor Abdul Wahab, we know him very well. He's really a committed guy. If the momentum starts from field epidemiology, it will go anywhere, manywhere, I mean. So maybe studies and the research he is raising, it might be within the field epidemiology as a one cohort. They do their project about sepsis. And this sepsis could be in different parts of the country. And then imagine we have, for example, 20 students in the field epidemiology. They do sepsis projects across many governorates. It will be amazing. So you bring all from different, and you come up with the local data, and then we'll address what has been mentioned before. The data come from developing country, from US, UK. It doesn't represent us because, for example, we have cholera, we have malaria, we have dengue fever. All these are not part of the other infection. So the cause of the sepsis in our country is different the cause of sepsis and somewhere else. So we'll bring our evidence locally, and then we say to the world, come to help us with our context, with our intervention, with our data. So I would highly recommend, if there is a way through Dr. Abdul Wahid and Dr. Huda in the field of epidemiology or community medicine students who really in this coming batch could do their project about sepsis. Just focus this year, call it sepsis year, in terms of awareness and then of research. This is really going to be, you will believe me, next year we will have a conference one day today about sepsis with evidence from Yemen, and it will be something amazing. And this will not really upset the policymaker. It will make them happy because our students, they do their project, they complete their degree, and they done something really amazing, which is badly needed and being widely ignored. You know what I mean? So if we create this kind of momentum and start about this, is what I keep saying, we need to be smart. We should not focus on the big things, small things, but sustainable and expandable. And I am sure we'll do something. Just this came to my mind how really we translate our words into action. Thank you.
Thank you very much. That's a very, very important point. We say data is king, because with data, you can actually build an argument. For example, if we want to highlight an issue, and then some people say, how many people are dying from this? And then we say, well, we don't know, but in other countries, they have this. That's an estimate. But we can actually pinpoint what are they actually dying of, or what kind of, is it wounds? Is it, post-operative? Is it, there's so many things we can know from data on the ground. And this only comes by collecting data on the ground, research, the study is done on the ground. And I'm so happy that some people who can actually have an impact because of their follow-on from students are here with us today. if we have the data, we can pinpoint the issues on the ground. We can attract the right skill mix. For example, we say this is the problem, and the experts, the world experts who are dealing with this are X, Y, and Z. We can bring them to contribute to their experience. Not just that, we can also, if there are gaps in training, you can easily influence the undergraduate training to fill these gaps. And we can also attract funding for other ongoing projects. And we can definitely be seen as a place that's actually doing it properly by actually looking at what's actually happening on the ground, presenting this data in a good way, and then leveraging on the experience by people who are leading in the world to actually implement changes and solutions. Once we clear the cycle, we'll be honestly taken very, very seriously anywhere we go in the world. And that's why we really want to build on that. That's what INTERYem is all about. Thank you very much.
Thank you, Dr. Khalid, for your suggestion, and we are happy and more than happy to help and support, as you said, such projects with our residents, and looking forward for more moving forward in these topics in the near future. Thank you very much for all. Thank you, Dr. Huda, also.
Yes, the same from my side. I'm welcoming any, activity that could be beneficial. Yeah.
Amazing. Thank you. We will definitely be in touch with you. Please, bear with us and stay with us, and we welcome your feedback. At the end of the day, we are the furthest away from Yemen than you. So what we think is the best may not be actually what's actually needed to be done on the ground. You have the closer you are, the more informed you would be. Thank you very much. Does anyone else has anything to add, please? So I think probably this is a good time to conclude. We have got no other questions on the chat, and we have had a very constructive day, and I'm really, really pleased that we have got some ideas that we can actually pursue and build on. And thank you very much for everybody who attended today. We look forward to see you in the public health conference next week. Please remember to do the feedback so you can automatically be issued a certificate. The feedback and certificates are linked, so if the feedback is not done, the admin team are not generating a certificate. I will also be, even speakers, likewise, for example, I will do a feedback myself so that I can get a certificate as well. If anybody has any follow-ups, please feel free to email us or send us a message once we add you to WhatsApp group if you haven't been added. And